Hello, my dear doctors. This is Dr. Azam here, your faculty of anatomy at PrepLadder. And a very warm welcome to all of you. And today we are going to start with the Rapid Revision Reignite here. And the very first session of this one here, anatomy. And as we have already informed you, the test was live at 12 o'clock. I hope you have attended the test. And now we are going to do the discussion of all those questions which were given in the test over there. Yeah, a very good evening, everyone. A good evening, everyone here. So let's get started with the discussion right now. I hope all of you have written the test. Please confirm me if my audio and video is perfect here. Yes, a good evening, a very good evening to everyone, guys. So now let us get started with our discussion here. Okay, fine. Dr. Mohammed Tufail, do attend the test. It'll be going to help you a lot. Okay. Come on, guys. Thank you, Dr. Spidey. Thank you. Now, my dear friends, let's get started with the very first question here. Moving ahead with this one here. Of course, I'm going to discuss like all the important concepts here. With the question, we are going to discuss the entire concept. So please be patient over there. Be along with me till the end of this session, and you're going to gain a lot here. And especially the students who are going to prepare for their exams further, this is going to be like a wonderful session for you guys. Okay, so let's get started with the first concept here. So a 50-year-old man sustains a minor cut while working with a metal sheet. The injury is located on the medial aspect of his palm. The medial aspect of his palm here near the wrist. He complains of numbness over the little finger and the medial half of the ring finger on the palmar side. Okay. There is no motor weakness of the fingers. Which of the following structure is most likely injured? I hope already you got an idea here. Whenever there is a numbness over this little finger and medial half of the ring finger, we know that the skin over this one will be supplied by ulnar nerve. So when the skin is supplied by ulnar nerve over here, of course, we can see in the option here that is ulnar nerve, and the ulnar nerve is given over there. But we need to find out whether it is the deep branch or the superficial branch of the ulnar nerve. So now what we are going to do is, better we do one thing here. Let's have a complete revision of the ulnar nerve, the entire course of that and the supply. So first of all, in this diagram, you're able to see this one here will be the lower end of the humerus here. And this lower end of the humerus here will be having the lateral epicondyle as well as the medial epicondyle. Now in this diagram, you can see this one here will be the arm. And we know very well that in the arm, ulnar nerve does not have any supply. Yes, if you have attended my videos, if you have watched my videos, you know very well, according to our golden rule, the anterior compartment of the arm will be supplied by musculocutaneous nerve and the posterior compartment of the arm will be supplied by a radial nerve. So ulnar nerve is not going to supply to any muscles in the arm. Now after that, now another very important thing which is being repeatedly asked in your exams is ulnar nerve is going to pass behind the medial epicondyle. You can see in my diagram there, I have drawn with a dotted line. So remember, it is going to pass behind the medial epicondyle. Now after passing from there, it is going to enter into the forearm. Now in the forearm, remember, it is going to enter by passing between the two heads of a muscle. And that muscle here will be the flexor carpi ulnaris muscle. Between the two heads of flexor carpi ulnaris muscle. And there is one more important point there. There you'll be actually able to find cubital tunnel, and it is going to pass through the cubital tunnel. Now sometimes what is going to happen, ulnar nerve is getting compressed over there, and due to that it is referred to as a cubital tunnel syndrome. Please be very careful with the carpal tunnel syndrome. Don't get confused with that one. Yes, in the carpal tunnel syndrome, median nerve will be involved. So we have learned like two MCQs here. Ulnar nerve is going to pass behind the medial epicondyle. And yes, what is the nerve involved in cubital tunnel syndrome? It will be ulnar nerve. Now when it comes to forearm, in the forearm, ulnar nerve will be actually supplying to medial 1.5 muscles. Of course, ulnar nerve will be supplying to the muscles in the anterior compartment of the forearm, but not all the muscles. It is just supplying to medial 1.5 muscle. And the one complete muscle will be flexor carpi ulnaris muscle and half of flexor digitorum profundus muscle, medial half of the flexor digitorum profundus muscle. That's all about in the forearm. Now from the forearm, the ulnar nerve is going to enter into the hand. Now how it is going to enter into the hand, this is also very much important. Remember, it is going to pass superficial to flexor retinaculum present over here. So this one here will be the flexor retinaculum and ulnar nerve is going to pass superficial to that one. तो आप ऐसे याद रख सकते हो, ulnar ऊपर, है ना. At PrepLadder here we have done the videos both in English as well as in Hinglish there. तो आप थोड़े से ना निमोनिक्स English में भी याद रख सकते हो कि ulnar ऊपर, ulnar कहाँ से पास होगी, superficial to flexor retinaculum, कोई confusion नहीं होगा. And here also what is going to happen here, the ulnar nerve will be actually covered by ligament here, that is volar carpal ligament. Because of that there is a canal formed here. That canal will be the Guyon's canal. Guyon's canal, even that question also has been asked in the exam. So what is a nerve that is going to pass through the Guyon's canal? That is your ulnar nerve. Next, after that, now please pay attention here, this is very much important. Once the ulnar nerve is going to enter into the hand here, it is going to divide into superficial branch and the deep branch. Out of these two branches, remember, the superficial branch of the ulnar nerve, the superficial branch of the ulnar nerve is supplying to only and only one muscle, that is palmaris brevis. And that palmaris brevis belongs to hypothenar group of muscles. And apart from that, it is supplying to the skin of the medial 1.5 hand. Now, when I'm telling you hand here, I mean to say it is supplying to the skin of medial 1.5 palmar surface as well as the medial 1.5 dorsal surface. So this entire thing will be taken care by the superficial branch of the ulnar nerve. Okay, so that is what is actually our question about. So superficial branch of the ulnar nerve is supplying to the skin on the medial 1.5, yes, hand here. And after that, the deep branch is taking care over the remaining muscles. I mean to say the remaining hypothenar muscles over here. Then after that, the lumbrical number 3 and 4 here. And after that, all the interossei, the 4 palmar, the 4 dorsal interossei, all of them will be supplied by ulnar nerve deep branch. And finally, remember that the ulnar nerve is going on the other side and it will be ending in a muscle known as adductor pollicis. Now, because it is ending in the adductor pollicis over there, that is why that muscle is referred to as graveyard of the ulnar nerve. Graveyard of the ulnar nerve, sir. Fine. So by this you can observe here, with one question we are discussing like everything possible over there, so that it is going to definitely help in your exams, my dear friends. Okay. Now an important thing, yes, of course, it is also asked in your PG exams. When ulnar nerve is supplying to the adductor pollicis muscle over here, of course, what is a test for that one? I hope you all remember book test. Okay. Now, whenever someone is giving me a book here, I'm going to hold the book by adducting my thumb here. Adductor pollicis muscle will be used there. Now just imagine that ulnar nerve is injured. If the ulnar nerve is injured, then what is going to happen? I'm unable to hold the book there. I mean to say I cannot do the adduction, so I'll be doing the flexion. Now if you see that thumb is bent over there, that sign is referred to as the Froment sign, which will be positive over there. Okay, and that was a question given in the PG exam. Froment sign will be positive. Yes, what is a test? Book test, and it is done for which nerve? Of course, for the ulnar nerve. Okay. So I think we have covered almost like every point over here, my dear friends. Yes, of course, the correct answer here, if the person is having numbness over the little finger and the medial half of the ring finger, of course, the nerve that has to be involved will be the superficial branch of the ulnar nerve, sir. That is the superficial branch of the ulnar nerve. I hope the concept is like crystal clear, my dear friends. Okay, yes, perfectly correct, Dr. Mayank Jain. Perfectly correct, Dr. Jyoti over there. Perfect answer. Okay. चलिए आगे बढ़ते हैं. I hope you're understanding here the way I'm going to discuss all the questions here with you. Yes, we are going to discuss the entire concept here, my dear friends, so that it will be able to, you'll be able to solve the other questions also possible from here. Okay. Now, come on, let's go ahead right now. Identify the papillae shown below in the given diagram here, whether it is circumvallate, fungiform, filiform, or foliate papillae. Now, my dear friends, I'll tell you one trend here. In your INI-CET exam previously, of course, tongue topic was very much important. And they used to ask the questions from the muscles of the tongue and importantly from the nerve supply of tongue. Now, all the students are very much perfect with the nerve supply of the tongue. When it comes to like sensory supply, I hope you remember my mnemonic 5, 7, 9, 9, 10, 10. For the anterior 2/3, posterior 1/3 and posterior most part. Fine. Now, we all know that nerve supply very well. But recently what happened in the INI-CET exam, they started with this new question there asking about the papillae of the tongue. About the papillae of the tongue. Okay, that is the reason why in this test here I have included this question. Nerve supply to sabko pata hai. Everyone knows about that one. So now, now my dear friends, we are going to see about the papillae. Let us discuss about all the papillae one by one. Now, first of all, in this diagram, you are able to see that this one here will be the filiform papillae here. Okay, And this filiform papillae will be conical shaped papillae. And remember the epithelium, they're actually having keratinized one. It is keratinized stratified squamous epithelium. That is also an important MCQ. Then the second one here, which are actually mushroom shaped here, that will be the fungiform papillae here, sir. And that fungiform papillae will also have the stratified squamous epithelium over there. But the keratinized one will be the filiform. That is a point to remember here. Okay, I hope you're able to identify the shape also. We have highlighted it very clearly. Now after that, now this one is another important one. This was given as an image-based question in the exam, that is circumvallate papillae. How to identify the circumvallate papillae? Yes, you can clearly see the surface over here will be more broader when compared to the base, that is more narrower. And the most important feature here is this deep trench which is present over here. With the help of this deep trench, you'll be able to identify that it will be the circumvallate papillae. Fine. And then apart from that, the last and final one, this one here will be the foliate papillae over here. Okay. Now let me tell you certain important points regarding all these papillae that you have to remember. Why? Because nowadays in the tongue topic, they're asking questions from the papillae of the tongue rather than the nerve supply and all. Okay. So now fungiform papillae, they are scattered over the entire surface of the tongue. Fine. I told you fungiform, from the name itself you can remember, they are like mushroom shaped. Fine. Now the second one, this is very much important, that is your circumvallate papillae. And circumvallate papillae, when you look at the diagram of the tongue here like this here, sir, conventionally we'll be dividing the tongue into the anterior 2/3, the posterior 1/3, and the posterior most part. Where exactly the circumvallate papillae are located here? They're located in the anterior 2/3 here, in that V-shaped arrangement. Anterior 2/3 in the V-shaped arrangement. That is something really important. Fine. They're large and circular papillae with the trench, as I told you, with the deep trench on either side. Then the filiform papillae here, they covers the entire dorsal surface of the tongue. They are slender, thread-like, but important point to remember, they don't have any taste buds. They are not having any taste buds. And foliate papillae are present towards the lateral surface of the tongue. And then, yes, of course, you can easily remember all these points over here. Now the most important thing, one more important thing that you have to remember is, in the anterior 2/3 of the tongue, my dear friends, remember the nerve supply is by 5 and 7. I mean to say, the seventh nerve, facial nerve, chorda tympani branch, it is going to carry the taste sensation. And then the fifth nerve, that is your trigeminal nerve, it is going to carry the general sensation. Of course, trigeminal nerve, which branch? Mandibular nerve. And which branch of the mandibular nerve? That is the lingual. It is going to carry the general sensation. But except which one? Remember, except the circumvallate papillae. Circumvallate papillae, from here, the taste will be carried by the ninth nerve, that is glossopharyngeal nerve. Even though it is present in the anterior 2/3, from there it will be carried by the glossopharyngeal nerve. Now, these are all the points. These are all the points you have to remember about the papillae here. So, fine. Now, in this diagram, yes, what is the papillae given after all the discussion? I hope you are easily able to identify right now. This one here will be the filiform papillae here. So, that is a filiform papillae. Yes. Perfectly right, my dear friends. Now, moving on to the next question. Which among the following muscles are supplied by the deep branch of the peroneal nerve? Okay. Now, again, the same thing. Try to recall from our golden rule here. Hello, my dear friends. Now, in the lower limb, in the thigh, you'll be actually having three compartments. All the muscles are divided into like three compartments in the thigh. Anterior compartment will be supplied by femoral nerve. Medial compartment will be supplied by obturator nerve, and the posterior compartment of the thigh, it will be supplied by sciatic nerve. Of course, it is having two components, the tibial and the common peroneal. Fine. I hope you're able to recall. Now from the thigh, if you move down into the leg region, again in the leg region, you're having three compartments. One is anterior compartment, another one is posterior compartment, and lateral compartment. Now remember, the posterior compartment of leg will be again supplied by tibial nerve only, whereas the lateral compartment of the leg is supplied by superficial peroneal nerve, and the anterior compartment of leg will be supplied by deep peroneal nerve. So now please remember here, the deep branch of the peroneal nerve, it will be supplying to all the muscles in the anterior compartment of leg. It is supplying to anterior compartment of the leg. Okay, now what are the muscles that you have in the anterior compartment of the leg? Of course, there will be tibialis anterior present there. And after that, you'll be also having in the anterior compartment, do you have extensors or flexors? you'll be having extensors, है ना? So there you'll be having the extensor hallucis longus and extensor digitorum longus is also present over there. Apart from that, you will also have peroneus tertius muscle. This was also given recently in the exam. Remember, peroneus tertius is present in the anterior compartment. Whereas in the lateral compartment of the leg, you'll be having peroneus longus and peroneus brevis. So this one will be present in lateral compartment of leg. And that will be supplied by superficial peroneal nerve, sir. Superficial peroneal nerve. So therefore, my dear doctors, please remember, deep peroneal nerve will be supplying to A, B and D. So the right option here will be answer A here. So option A here. Yes, perfectly right there. I hope you're answering the correctly here. Now moving on to the next one here. Yes, of course, this is the diagram that you're able to observe here. We are able to appreciate the tibialis anterior muscle here. Along with that extensor digitorum longus muscle here. Extensor hallucis longus muscle here. And remember, peroneus tertius. Peroneus, wherever the word comes at peroneus, you can actually replace that with the fibrillaris also. It is also known as fibrillaris. So don't get confused with that name. It is fibrillaris tertius, nothing but peroneus tertius. Perfectly done. By this, we have revised about the lower limb, the golden rule, all the compartments and their nerve supply, as well as the anterior compartment of the leg here. Perfectly done here, sir. Now moving ahead, a 40-year-old male with the nasopharyngeal carcinoma presents with trismus and pain near the infratemporal region. Which cranial nerve is most likely involved? First of all, trismus, that is the log jaw. Now I'm actually seeing your chat box over there, my dear friends. Can you please tell me what is the muscle that is involved in trismus, most commonly involved in trismus? What is the muscle that is most commonly involved in trismus, sir? Out of all the muscles of mastication, which is most commonly involved in trismus? If you ask me, when you're preparing for your PG exams, whether you're preparing for your INI-CET and NEET PG, especially for INI-CET, if you ask me, sir, tell us one topic. I want to get like that one question perfectly correct. If tell us one topic from where definitely the question will be asked in the exam. In INI-CET exam, they don't get tired of asking the muscles of mastication. तो आपको वो definitely पढ़ के जाना होगा exam से पहले. Before the exam, please study that nicely and go to the exam. Why? Because they definitely ask one question from the muscles of mastication. That is the reason why I have included this question over here. We are going to discuss everything about that one. Is it okay? Yes, my dear friends. Someone is answering masseter over there. Now, please remember, medial pterygoid will be the correct answer. Medial pterygoid muscle will be the right answer. Remember like that, sir. Fine. Now here in the trismus, if medial pterygoid is involved, we know very well, yes, my dear friends, all the muscles of mastication will be supplied by which nerve? That will be supplied by mandibular nerve. That is your 5-3. So the correct answer here will be the 5-3. That is your mandibular nerve. Now, once you got the correct answer here, let us do one thing here, my dear friends. Let us discuss all the points regarding muscles of mastication. So as I have promised you, we are going to discuss like all the concepts here, very high yield concepts here. Let us discuss. Now we all know that in total we are having like 4 muscles of mastication. Number 1, this muscle here, which is attached onto the outer surface of the mandible here, near the ramus of the mandible. This one will be the masseter muscle. This is masseter muscle over here. And this big muscle here, which is beautiful fan-shaped muscle here, this one will be the temporalis muscle here. This is temporalis muscle here. Now, these two muscles, any student can identify. Even a first year MBBS student can identify the masseter and temporalis. In exams, they're actually confusing you with the lateral pterygoid and medial pterygoid. So if you look at this diagram here, in this diagram, there is one muscle which is going and getting attached to the capsule of temporomandibular joint. Now that which is attached to the capsule of temporomandibular joint, this muscle here will be the lateral pterygoid muscle. So this one here will be the lateral pterygoid muscle. I'm just writing there as LP, pterygoid, lateral pterygoid muscle. And this one here again will be the medial pterygoid, which is again attached to the ramus of the mandible, but from the inner aspect. So first learn how to identify. Now here itself, let me tell you like one more important point here, my dear friends. In temporalis muscle, the posterior fibers are actually more horizontal. The posterior fibers are more horizontal. So when they are going to contract, it is going to help in a retraction of the mandible. Okay, it makes sense here. These posterior fibers which are like more horizontal, when they are going to contract, it is helping in retraction of the mandible. Okay, number one. And these vertical fibers here, when they are going to contract, it is going to help in elevation of the mandible. It is going to help in elevation. So from here, we understand that temporalis actually has got two functions, elevation and retraction. Now, suppose if I give you both the options in the exam, in recently one of the exam it was given, what is the function of temporalis? Yes, elevation as well as retraction. If both the options are given, which is more better option? Come on, which is more better option? Yes, elevation is more better option. Very nice, Dr. Dinesh there, Aparna Dinesh. So elevation is more better option than a retraction. Please remember this. So we are done with one question here. Now let us move ahead. I'll give you certain points here. Follow this one by one, sir. About the muscles of mastication. First of all, what about the nerve supplied to all the muscles of mastication? All the muscles of mastication will be supplied by mandibular nerve. That is your, yes, 5-3. Third branch of your trigeminal nerve, sir. The mandibular nerve is supplying to all the muscles of mastication. Perfect, perfect, very nice. I'm really happy. Many of you have answered the correct answer here, sir. Elevation karke. Now, depression or opening of the jaw. Now, please remember here, whenever you are chewing, mastication here, the mandible is going to move up and down. That is elevation and the depression of the mandible. Fine. Depression of the mandible is very much easier. Why? Because the mandible will easily move down due to gravity. So therefore, you don't require like many muscles for that one. You require only one muscle. And that muscle will be the lateral pterygoid muscle. Lateral pterygoid muscle is the one which will be helping in depression of mandible, opening the jaw. So please remember L for lateral pterygoid and L for lowering the jaw. Now here, don't think that, I am not teaching you the muscles which are required for elevation of the mandible. Remaining three muscles are going to help in elevation. In that way, you try to study smartly here, because they're asking like many questions from muscles of mastication. You should be able to answer it very quickly. So remember, only one muscle is required for depression of mandible, whereas elevation is done by remaining three of them. Now, what about the retraction, sir? Just now I told you, retraction is done by temporalis muscle. Retraction is done by the temporalis muscle here. Just now I told you. It means the remaining three of them will be actually helping in what here? They'll be helping in protraction, guys. Protraction. Now the sidewise movement of the mandible, of course, it is done by the alternate movements of the pterygoid muscles, sir. The lateral pterygoid and the medial pterygoid. Alternate movements of that one will be helping in sidewise. Now the accessory muscle of mastication. Even this was also asked in the exam. And this one here will be the buccinator muscle. Accessory muscle of mastication will be the buccinator muscle, which is present in your cheek, and that is actually helping in blowing the cheeks here. Something like this here, you know. And most commonly involved in trismus, remember this one will be the medial pterygoid muscle. Medial pterygoid muscle. And please remember, trismus is like lockjaw. Lockjaw, it is mute medial pterygoid. So that you don't get confused between the lateral pterygoid and the medial pterygoid here, sir. So for lowering the jaw, lateral pterygoid, whereas in the mute, that is locked jaw, that will be the medial pterygoid. Okay, now one more important MCQ here is that most commonly involved in the locked jaw while yawning. So while yawning, what is going to happen? The person is going to open the mouth. Of course, that is done by yes, lateral pterygoid. So the correct answer here should be the lateral pterygoid muscle. So I hope all the MCQs are covered here. If you follow this, you will be able to answer all the questions from your muscles of mastication, sir. Perfect. So therefore, in our question here, yes, in trismus, yes, of course, the nerve that can be involved here will be the mandibular division of the trigeminal nerve. So perfectly done. And we have revised the entire concept. Yes, as I told you, one concept that definitely the question will come in your INI-CET exam will be from the muscles of mastication. Please revise that before going to the exam, sir. Let's go ahead with the next question right now. I should actually say the next concept. Okay, not even like next question. We are dealing like concept by concept here. So let us go ahead with the next concept right now. A 45-year-old man presents with waddling gait and difficulty climbing the stairs. Okay. On physical examination, when he is asked to stand on the right leg, please be careful. On his right leg, his pelvis drops on the left side. Pelvis drops on the left side. Which of the following structure is most likely injured? Okay, let me tell you. Basically, we are dealing with what here, sir? We are dealing with the Trendelenburg sign. This is another very important concept, Trendelenburg sign. Okay. Now, normally what is going to happen, the gluteus medius and the gluteus minimus muscle, these two muscles will be supplied by superior gluteal nerve. Superior gluteal nerve. Now, in the normal people like you and me, what is going to happen? While walking, for example, the right foot is on the ground here and the left foot is off the ground here. Obviously, the left side of the pelvis will not be supported, so therefore it should actually drop. But it is not dropping in the normal people like you and me. Why? Because exactly opposite side will be having gluteus medius and minimus, and they are the one which are going to contract and they are helping in abduction at the hip joint. So what is the function of this one? Abduction at hip joint. And not only abduction at the hip joint, they also help in the internal rotation. And after that, remember one more thing, they are going to stabilize the pelvis while walking. It is going to stabilize the pelvis while walking. And this is how they are going to stabilize. So when the pelvis is trying to drop on the left side, yes, the right side, gluteus medius and minimus will contract and that is going to abduct and the person is walking very nicely. Now just imagine a situation where superior gluteal nerve is injured. Then what is going to happen? This gluteus medius and minimus muscle, they are not working, they are paralyzed. Now when the person is trying to walk, what will happen? The left side of the hip will sag, it is going to drop. Now because this left side of the pelvis is dropping over here, then what is going to happen? How the person will walk? How will be the gait then? Because opposite side gluteus medius and minimus, they are not working. So therefore what is going to happen? To compensate that, he'll take the help of upper half of the body. So upper part of the body will be shifted onto the opposite side so that the hip can be abducted and then the person is going to walk. So when the person is bending on one side and walking, that type of gait will be like lurching gait. If he's like bending on both the side, that is referred to as the waddling gait. Like the penguins will walk, and penguins will be walking with the waddling gait over there. That is the entire concept here. Now the important thing that you have to remember, please follow my example here. In this example, you can clearly see, yes, if the right side gluteus medius and minimus are paralyzed, I mean to say, if the right superior gluteal nerve is gone, then the hip is actually dropping towards the left side. So vice versa, if the hip is actually dropping towards the left, that means which side nerve is gone? Contralateral side nerve will be gone. So keep one example in your mind. Suppose if the hip is dropping on the left side, then the right superior gluteal nerve has to be involved. That is like crystal clear concept. Okay. Now, welcome back here. When the person is asked to stand on his right leg, his pelvis drop on the left side. If the pelvis is dropping on the left side, obviously, right superior gluteal nerve will be involved. So the correct answer here will be the right superior gluteal nerve. Inferior gluteal nerve cannot be the answer. Why? Because it is the one which will be supplying to gluteus maximus muscle. It has nothing to do with the Trendelenburg sign over here. Fine. So out of that right and left, I hope you are able to understand the concept crystal clearly here, sir. Perfect. Yes, Dr. Amandeep. Nowadays it is like trending. I also have seen that some certain songs and all. Yes, something trending on the Instagram there. Exactly that. It goes with the notes of that that song. Now let us move ahead with the next question over here, my dear friends. Yes, which of the following statement regarding the site of palpation of the peripheral pulses is true? Now I have given you the question paper in such a balanced way that after completing certain like good concepts over here, like certain things to actually memorize over there and try to see like where exactly they are located. Now, which of the following statement regarding the site of palpation of peripheral pulse is true? Okay. Radial artery is palpated medial to the tendon of flexor carpi radialis at the wrist. Of course, this is the wrist here. On the lateral side, you'll be able to see the flexor carpi radialis tendon here, and just medial to that one, you'll be able to palpate the radial artery. So this is absolutely true here, sir. Next one. Which of the following statement is true? Yes, of course, they're asking the true statement here. So radial artery pulse is palpated medial to the tendon of flexor carpi radialis. Okay, they're actually the true statement here, my dear friend. Remember, it is actually present towards the lateral side here. So this one will be a false statement here. Done. Then brachial artery pulse is palpated medial to the biceps brachii tendon in the cubital fossa. So I hope you remember in the cubital fossa, we have a mnemonic that is like MBBS, from medial to lateral. All the structures are arranged in the form of MBBS, from medial towards the lateral. So now where is the brachial artery present over here with respect to biceps brachii tendon? It will be present towards the, yes, medial side. So absolutely correct over here. So when it comes to the biceps brachii tendon, remember that will be present lateral to the brachial artery, or we can say the brachial artery is present medial to the biceps brachii tendon. That is also the correct option here. Now after that, moving ahead, sir, common carotid artery pulse is palpated at Chezachnak's tubercle at C3. Remember, common carotid artery is palpated at this tubercle, Chezachnak's tubercle, or else it is also referred to as carotid tubercle. But remember, it is not C3 here. It will be C6. So it's actually a wrong option there. Posterior tibial artery pulse is palpated between the lateral malleolus and the tendocalcaneus. Remember, posterior tibial artery is passing through the tarsal tunnel, and tarsal tunnel is actually present, yes, towards the medial side, not towards the lateral side. So it cannot be the lateral malleolus, it has to be like medial malleolus. So this is also the wrong one. This is also wrong one. Dorsalis pedis artery pulse is palpated lateral to the extensor hallucis longus tendon on the dorsum of the foot, and this is the correct option here. So the right answers here, it is asking like the true statement here. Yes, of course it will be B and E over here, sir. This is the right answer here. This is the right answer here, sir. Fine. Now after that, a forensic report, that was like a simple concept there. So that is why I am telling you, I have just kept all the questions like a balanced here. Now let us move on to the next concept here. A forensic report of a fatal head injury mentions fracture at the Pterion. Okay, I hope you all know this Pterion. It is like trending question nowadays in almost every form of the exam. Every form of the exam, Pterion. An associated epidural hemorrhage will occur. Of course, at the Pterion, if there is a trauma, it will lead to epidural hemorrhage. Which cranial fossa in this region is most closely related? Remember, if the Pterion is getting hit here, yes, the cranial fossa which will be, yes, associated with that one will be the middle cranial fossa. Apart from this, let us quickly recall all the points regarding the Pterion. That is also a potential question in your exam, sir. Potential question in your exam, sir. Fine. Now remember, the Pterion will be actually a H-shaped suture here. It will be a H-shaped suture. It is formed between the four bones. This one here will be the frontal bone. This one here will be the parietal bone. And this here will be the squamous part of the temporal bone. And then this one here will be the greater wing of the sphenoid. And between all of them, there will be Pterion present here. Now, most of the time in your exams, they're asking about the relations of the Pterion. What are the deep relations of the Pterion? Now, when you just see inside the Pterion, there will be middle meningeal artery. And middle meningeal artery will be actually having two divisions here. And out of the two division, remember, the division which is going towards the frontal bone, I mean to say anterior division. Anterior division is the one which will be present just beneath the Pterion. So we can answer that as anterior division or the frontal division of the middle meningeal vessels. Apart from that, inside here, you'll be able to appreciate the cerebral hemisphere here. And this sulcus here will be the lateral sulcus. So lateral sulcus or the sylvian fissure, the beginning of that one, you'll be also able to see just beneath the Pterion. And then inside that lateral sulcus, you'll be able to appreciate, of course, the middle cerebral vessels. So these are all the structures that are present inside, just inside the Pterion. Please add one more point over there. Yes, just inside the Pterion, you'll also be able to appreciate the lesser wing of the sphenoid. There will be lesser wing of the sphenoid, sir. Now, please don't get confused here. Sphenoid is formed by the Pterion will be formed by greater wing of sphenoid. Pterion is formed by greater wing of the sphenoid, but inside that there will be lesser wing of the sphenoid, and that is also a important question already asked there. Now welcome to the clinical anatomy here. Suppose if you're getting a hit at this Pterion, then what is going to happen? Of course, the middle meningeal artery will be ruptured, and rupture of middle meningeal artery will lead to what here, sir? It will lead to epidural hemorrhage here. Rupture of this middle meningeal artery will lead to epidural hemorrhage. Of course, that very famous one, idli shaped hemorrhage or that biconvex shaped hemorrhage will be there. And then apart from that, remember one more important point there, lucid interval. Whenever they are giving a clinical question, they'll be including, yes, the person will be having lucid interval. That patient will be having lucid interval. Fine. Perfect. So if you remember these many points over here, of course they are going to help. Yes, of course, Dr. Rohit, Broca's speech area present over there. Next one, I'll let you know about the Broca's speech area also later on when we are going to discuss the further questions here. Now moving on to the next concept here. A 14-year-old boy A 14-year-old boy presents with involuntary, slow writing movements of his hands and feet that worsen with voluntary activity. Okay. His parents report a history of kernicterus in infancy. Okay. Coronal section of the brain shown below reveals the damage to the structure marked by the arrow here. Okay. The arrow mark is present over here. And this is the structure which is damaged here. Which of the following describes the role of this structure? Basically, if you look at the diagram there, first you should be able to identify the diagram there. It's actually marking at lentiform nucleus. In the lentiform nucleus, the outer part will be the putamen and the inner part will be the globus pallidus. So this part here will be actually the globus pallidus wala part. Globus pallidus wala part. And that will be actually involved in the pathways of the basal, that will be involved in the pathways of the basal ganglia. I hope you have learned in the neurophysiology part, there will be direct and indirect basal ganglia pathways will be there. So that part, that is globus pallidus internus, will be involved in the pathways of the basal ganglia. And we know very well that is concerned with the movement, the planning of the movement, the functions you remember about the basal ganglia. And whenever there will be lesion in that one, it will lead to all these type of disorders related with the movements. I think you have learned about that chorea, athetosis and all those things. Yes, the movement disorders will occur whenever there is a lesion in the basal ganglia parts. Now here, let us see the option one by one here. If there is a lesion at this globus pallidus internus, that is the one which is actually going to inhibit, it is going to inhibit the thalamocortical neurons. Thalamocortical neurons. Fine. Thereby it is going to suppress this unwanted movements. But here it is happening here. The involuntary movements are happening here. So what is going to be option here? The option B will be the right one here. It is going to inhibit the involuntary movements via the thalamus. I told you, right? Thalamocortical neurons. Understanding? So it is going to inhibit the involuntary movements via the modulation of the thalamus. I hope it is crystal clear concept over there. Then, now why I have given this question here, remember in your exam, definitely they'll be giving a section of the brain. So in all the three sections of the brain, whether it is sagittal or coronal or transverse, you should be perfect in all the three sections of the brain. Now in this, we are seeing the coronal section of the brain. And in this coronal section of the brain, you're able to see this is the lentiform nucleus here. There will be a caudate nucleus here and thalamus. In between them, there will be internal capsule that is going to pass from here. So you should always be ready to identify the parts of the basal ganglia over here. They're all the parts of the basal ganglia here, sir. Okay, ना? चलिए आगे बढ़ते हैं. Let us go ahead right now with the next question. A newborn presents with fused lower limbs as shown in the image below. This congenital malformation strongly is associated with the maternal pre-gestational diabetes, primarily results from a defect in which of the embryological process here. Okay, now in this given image, if you are able to observe there, it is actually cyanomelia, mermaid syndrome जिसे कहते हैं, mermaid syndrome जिसे हम कहते हैं. अब यहाँ पर प्रॉब्लम क्या है? The problem here is with the incomplete mesoderm formation. Now why I'm telling you the problem is with the incomplete mesoderm formation? You know very well, mesoderm is the one which is going to form those the bones, the cartilages, the muscles, and all those things are actually formed from mesoderm only. Now what is going to happen here? Near the caudal region, if the mesoderm is incompletely formed, the bones, ligaments and everything will not be formed. It will be leading to this mermaid syndrome there. So that is the correct answer here, sir. Failure of neural tube closure, it cannot be the answer here. Why? Because the failure of neural tube like cranial neuropore, it will lead to anencephaly. The caudal neuropore, it will lead to spina bifida, and that rachis and all, that's all totally different. It is not associated with this mermaid syndrome here. That is not the right answer here. Abnormal development of the first pharyngeal arch, no. First pharyngeal arch, it is going to form the structures over here like malleus, incus, anterior ligament of the malleus, sphenomandibular ligament, mandible. All these structures are actually formed from the first pharyngeal arch. So that cannot be the answer here. Defective formation of the notochord. Notochord is actually concerned with the formation of, inducing the formation of neural tube and all those things. Okay, so that cannot be the answer. So the correct answer here is incomplete mesoderm formation in the caudal region of the gastrulation. Why? Because mesoderm is the one which is going to form all the structures like bones, ligaments, tendons, and all those will be formed here, sir. Of course, Dr. Devanshi Sharma, it is actually for the INI-CET. We are discussing all those concepts which are very, very much important for your INI-CET exams here. Next one, sir. A 30-year-old primigravida undergoes vaginal delivery with episiotomy. Post-delivery, she complains of perineal pain and loss of sensation in the posterior vulva and anus. A block of which nerve would have prevented this one? Now remember, the nerve which will be actually having sensory supply in the perineal region, okay, in the perineum, sensory supply, that nerve will be actually the pudendal nerve. Pudendal nerve, sir. Okay. So pudendal nerve is the one which will be actually having the sensory supply in the perineum region. So if that would have been blocked, this pain and everything should not be there, guys. Acha. Now, before moving ahead, let me ask you something. Let me see how much you are also actively involved in this session here. Can anyone tell me this pudendal nerve is going to turn around? It is going to move from greater sciatic foramen to lesser sciatic foramen by taking a turn around which structure? So pudendal nerve is going to move from greater sciatic foramen and to lesser sciatic foramen, taking a turn around which structure? Of course, that is the ischial spine. Very good, Dr. Dasari. So it is going to take a turn around the ischial spine. That is an important site. That is the site where you are actually going to do pudendal nerve block. And I hope you remember that very famous mnemonic where near the ischial spine where three structures are going to take a turn. One is your pudendal nerve. Another one is internal pudendal artery and vein, and apart from that there will be nerve to obturator internus. Nerve to obturator internus. Fine. Next, moving on to the next concept here. A 60-year-old patient presents with pain and difficulty in moving the hip after sustaining a fracture in the proximal femur. X-ray shown below. Which of the following movement is most it is actually lost due to this injury here, sir? Now, first of all, the one which is marked here will be the lesser trochanter of the femur. Now, why I have given you this question over here? Why? Because in your INI-CET exam, many a times they'll be asking the question related to attachments on the femur. Attachments on the bone of the femur. Fine. So first, let us look at all these attachments here, sir. Many a times they're asking the questions from here. So something related to that one, either the clinical anatomy or the action of the muscles they'll be asking. So attachments at the femur is very, very important topic for your INI-CET exam, sir. So please remember the attachments very well. So let us revise all the attachments one by one. Number one, in this diagram here, you'll be able to see here, this is your ASIS, anterior superior iliac spine. Of course, here two structures will be attached. Number one, from the anterior superior iliac spine, there will be a ligament, and that ligament will go and get attached to the pubic tubercle over here. And that ligament will be the inguinal ligament. Okay. And then one more muscle, that is the longest muscle, that is also going to originate from here. That is the sartorius muscle, sir. So inguinal ligament and sartorius muscle, they are going to be attached to ASIS. Number one point to learn. Number two, second point to learn here is anterior inferior iliac spine, और यहाँ पर attach होता है rectus femoris muscle. My dear doctors, quickly try to recall. There is a muscle in the anterior compartment of the thigh. The name of that one will be the quadriceps femoris muscle. Quadriceps femoris muscle. Quadri 4. The word ceps is coming from cephalus. It is having 4 heads. Vastus medialis, vastus lateralis, vastus intermedius, and in the front of that rectus femoris. So rectus femoris is going to begin from where? It's going to begin from anterior inferior iliac spine. Important one. Now, once you have learned about these two attachments, now let us go towards the gluteus maximus, gluteus medius, and gluteus minimus. This topic is very, very important topic for your INI-CET exam. Please remember this one, sir. The muscle that will be attached at the gluteal tuberosity, that one will be the gluteus maximus muscle. And gluteus maximus muscle is helping in extension at the hip joint. It will be helping in extension at the hip joint. For example, right now you are sitting there, I am sitting here. In a sitting position, our hip joint will be actually flexed. Now from the sitting position, when you are standing up, remember it will be done by the gluteus maximus. Okay. Extension at the hip joint is done by gluteus maximus. Similarly, like climbing up the stairs, the extension and external rotation is done by gluteus maximus. Now, my dear friends, remember, apart from that, gluteus medius and the gluteus medius and gluteus minimus, both of them will be attached at the greater trochanter. But what is the difference? Remember, gluteus medius will be attached onto the posterior aspect here on the greater trochanter, whereas the gluteus minimus will be attached onto the anterior aspect here on the greater trochanter. Okay, and both of them, just now I told you in the Trendelenburg sign, both of them are going to help in abduction at the hip joint as well as internal rotation also. And now welcome to lesser trochanter. The question that I have given you here, on the lesser trochanter, two muscles are going to attach. One is your iliacus, another one will be the psoas major. और जो सवाल मैंने आपसे अभी अभी पूछा था, जो आपने अच्छे से आंसर किया वहां पर, the three structures which are going to take a turn around the ischial spine, one will be pudendal nerve along with the internal pudendal artery as well as the internal pudendal vein here, along with nerve to obturator internus. So we remember this with the mnemonic as PIN. I repeat again, pudendal nerve, internal pudendal artery and vein, and then the nerve to obturator internus. All of them are taking a turn around the ischial spine, and they are going to move from the greater sciatic foramen and then into the lesser sciatic foramen. I hope all the concepts are covered here, sir. And attachment at the femur is very much important. Now, once you learn this concept, this is how we'll be actually teaching in our videos there. Once you learn this concept here, this is how they'll be actually asking you the questions. Now let us try to apply. So the structure which is marked here will be lesser trochanter, and on the lesser trochanter, iliacus and the psoas major will be attached. Now, which movement will be actually lost here? Which movement will be lost? Now remember, whenever the muscle is coming here and getting attached over there, when this muscle is going to contract, of course, the muscle which are present in front of the joint, they are going to help in flexion. They're helping in what? Flexion. So therefore, iliacus and psoas major, they'll be helping in flexion. So now, if that is gone, obviously it will lead to loss of flexion. Loss of flexion at the hip joints. Fine, perfectly done here, sir. So this is how you have to apply. But my main intention for all my dear students here, my main intention was, yes, revising this topic here, attachments at the femur. They can give you anytime the image-based question, be ready for that one, sir. Now the next question here, an anatomical image shows the lateral view of the oral cavity and the pharynx. All of the following arteries supply the marked structure except. If you look at this diagram here, the marked structure here will be the soft palate over here. And remember, it will be supplied by lesser palatine artery as well as the ascending palatine artery, as well as even the ascending pharyngeal artery is also going to supply to that one, but not the greater palatine artery. Not the greater palatine artery, sir. So they're asking you except, so the correct answer here will be the option A. So all the lesser palatine artery, ascending pharyngeal artery, all of them will be supplying to the soft palate except for the greater palatine artery, sir. Except for the greater palatine artery. And remember, that is the one which will be actually supplying to the hard palate. If you remember our videos, if you have watched my videos, sir, so this one here will be the hard palate. The greater palatine artery will be coming from here and it will be passing through this foramen, and it is also going to contribute to that area. That area will be actually referred to as the Little's area or Kieselbach's plexus. I hope you're able to recall from there. So at least try to remember from that diagram, my dear friends, that is actually responsible for supply to the, yes, hard palate, sir, not the soft palate over there. So except the greater palatine artery, I hope you're able to recall, sir. Now, once you are done with this one here, moving ahead. Which of the following statements about the modes of glandular secretion are correct? Yes, it is another trending question in your INI-CET exam regarding the glandular secretion, sir. Different types of glandular secretion, like, merocrine, apocrine, holocrine. So what I will do here is, first I'll let you know in detail about the concept. This also has been asked many times in your INI-CET exam, sir. First, we are going to learn that concept, then we'll come back and see all the statements one by one here, sir. So now please look at this diagram here. So glands, the glands are classified based on, one of the classification of the glands is based on the mode of secretion, sir. Based on the mode how they are secreting. Okay, now there are different classification of gland, like exocrine gland, endocrine gland. So different types of classifications are there. One type of classification of the gland is based on the mode of secretion. So based on that, there is merocrine, apocrine, and the holocrine. Now, what do you mean by the merocrine here? In this, what is going to happen? Whatever secretions that they're going to form, they are packed in the vesicles. The vesicles will come near the surface and they are going to secrete the substances by the process of exocytosis. Simple. Simple things here. In merocrine secretion, what is going to happen? Yes, whatever substances are actually formed there, they are going to be packed into the vesicle and they'll be coming near the surface and actually releasing the substance. Okay, that is known as merocrine. And here the examples are very much important. The examples for this one here will be the exocrine glands and the sweat glands. They are going to secrete by which process? Like merocrine. They come under the category of merocrine secretions. Now, what is the meaning of apocrine? In apocrine, what is going to happen? All the secretions are coming to the surface of the cell, and there a part of the cell is pinched off. You can clearly see in this diagram here, a part of the cell itself will be pinched off like a secretion. Okay. And yes, what are the examples of this one here? The mammary gland, as well as the atypical sweat glands in the axilla and pubis. Holocrine, what is going to happen here? The name itself is telling you holo. In this, what is going to happen? The whole cell. Remember like this, the whole cell. The mature cell itself is going to die. It is going to completely die. It is going to completely break down and secrete the entire thing, sir. And the example for this one will be the sebaceous glands. Example for this one here will be the sebaceous gland here, sir. Okay. And now let us see the correct options here. Welcome back to this one here. Number one, merocrine secretion releases a product via exocytosis without loss of cytoplasm. Yes, of course, this is a true statement here. अभी मैंने आपको बताया merocrine only secretions will be there without the cytoplasm there. Perfect. Apocrine secretion involves a partial loss of cytoplasm with the secretory product. Absolutely true here. This is also a true statement here. Apocrine, मैंने आपको अभी बताया था, yes, a part of the cell itself is lost along with the cytoplasm there. That is also a true statement here. Holocrine secretion preserves the cell structure after release of the secretory material. This is false. It is not the right statement here. It is a false statement here. In holocrine, holo, entire cell will actually be gone, sir. Okay. Sebaceous glands are the example of holocrine gland. Yes, of course, just now I showed you here. Sebaceous glands here will be the example of holocrine one. So this is also a true statement here. Mammary glands are the example of merocrine. No. Mammary gland is actually an example of your apocrine gland, sir. So therefore, this is actually a false statement. So out of all the given statements here, option A and option B and option D, these three will be the true statement here. Yes, of course, they're asking the correct statement here in the exam. Perfect, sir. Are you understanding here? But our intention, I hope you're understanding, it's not about just solving this question, sir. Our intention is this concept here. So in your INI-CET exam, they'll be asking about the glands. Many a times they're asking about the glands and their mode of secretion, based on the mode of secretion. Merocrine, apocrine, and holocrine. I hope this concept is also done here. Okay. So moving ahead, of course, I told you the correct answer here will be A, B, and D. Perfect. Which of the following structures are derived from the neural crest cells? Another hot favorite concept of the INI-CET examiner. I hope you remember they have asked about the parafollicular cells development. They've even asked about the conotruncal septum in that one. So many times the questions will be coming from here, sir. Okay. Now, my dear doctors, please look at this one here. Now, in this diagram, you are actually able to see the transverse section of the embryo. In this transverse section of the embryo, we'll try to do one thing here. Let me mark and you try to identify the structure, sir. If you will be able to do like quickly. Okay. Because this was also given as an image-based question here. So can you please answer me, what is this structure here? First of all, tell me what is this structure here, sir? Now, this structure, where you have taught about the glands, sir, it will be, of course, in histology. In histology, we have learned about that one. Yes, your study, you can actually go and watch in the Prep X videos, version X videos there. It will be there in the histology, sir. Yes, of course. This is the notochord here, sir. Perfectly fine. Now, if this is the notochord here, just above the notochord, you will be able to appreciate a tube-like structure here, and this tube-like structure here will be the neural tube. And remember, my dear doctors, just adjacent to the neural tube here, you'll be able to appreciate certain cells, and those cells will be the neural crest cells. They are the neural crest cells. Perfect. Now in this diagram, if this one here will be the transverse section, obviously this is ectoderm here, and this one here will be the endoderm here, and in the middle, this one here will be the mesoderm here, sir. So there'll be ectoderm, endoderm, and the mesoderm here, sir. Now this mesoderm will be the intra-embryonic mesoderm, and that will be divided into three parts here. This is paraxial mesoderm here, and this one here will be the intermediate mesoderm here, and this is the lateral plate mesoderm. I hope you're able to understand the paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm over here. Now, once in the exam, they have given this image, the transverse section of the embryo, and there was an arrow mark at this neural crest cells. So, neural crest cells derivatives is very much important topic for your exam. Now, let us let us try to, yes, understand here. Yes, of course, Dr. Debaki. Let us see all the answers here. What are the structures which are derived from neural crest cells? Of course, Schwann cells will be derived from there. Even odontoblast will be derived from there, as well as parafollicular cells, which are also referred to as C cells, are derived from there, sir, but not the retinal pigment epithelium. But not the retinal pigment epithelium here. So therefore, correct answer here will be the option A, C, and D, sir. This is the right answer here. Option A, C, and D, guys. Perfect. Let us move on to the next one. What I'm trying to tell you here is that please try to recall the neural crest cells derivatives before going to the exam. That is very, very much important. Moving on to the next concept here. A 35-year-old man presents with weakness in his right hand after penetrating injury to the forearm. On examination, he is unable to make an OK sign. Unable to make an OK sign. And his thumb and index finger, with his thumb and index finger, due to weakness in flexion at the interphalangeal joint of the thumb and distal interphalangeal joint of the index finger. So he is not able to make the OK sign here, sir. Which nerve is most likely injured? Now, when you have to make this OK sign over here, of course, we are actually helping in flexion over there. So therefore, what should happen here, sir? The flexor should work properly here. Now, try to recall from our golden rule that all the muscles in anterior compartment of the forearm will be supplied by two nerves, sir. That is your ulnar nerve, another one is median nerve. And in our discussion in the very first question, I taught you about the ulnar nerve very clearly. Ulnar nerve is just supplying to medial 1.5 muscle here. Medial 1.5. Flexor carpi ulnaris and the medial half of flexor digitorum profundus. Now remaining all these muscles here will be taken care by the median nerve. But not exactly the median nerve over here in the anterior compartment. What is going to happen here? Median nerve will give rise to a branch, and that branch will be the anterior interosseous nerve, AIN. AIN, and that is going to supply to the flexors over here. And suppose if that is gone, of course the person will not be able to make that OK sign with the thumb and the index finger. Okay, I hope you're understanding here, because it is the one which will be actually supplying to the deflexors. AIN, anterior interosseous nerve, which is in turn actually a branch of your median nerve only. It's a branch of median nerve only. Fine. And it is the one which will be supplying to deep flexors. Deep flexors. What do I mean by this one here? I mean that AIN is supplying, actually in the anterior compartment of the forearm, you'll be having two layers. One is your superficial layer, another one is the deeper layer. Now in the deeper layer, you're having FDP muscle, flexor digitorum profundus muscle. And flexor digitorum profundus muscle, if you people have seen those images, that the four tendons will be going into the digits up to the distal phalanx here. Up to the distal phalanx here. That means it is going to help in flexion at, yes, interphalangeal joints here. The proximal and the distal interphalangeal joint over here. So therefore, my dear friend, if that deep flexors are gone, it means the AIN is actually gone. Anterior interosseous nerve is actually gone there. So therefore, the person will not be able to make that OK sign there. Is it okay? Yes, of course. Yes, of course. That is the reason why I have included here. Please remember, anterior interosseous nerve is very much important. So basically, one more thing that we have to understand from here, from our discussion here, that before going for your INI-CET exam, please recall the major nerves, sir. In the upper limb, you have to remember about the ulnar nerve, median nerve, and the radial nerve. One question will definitely come from there. So whenever preparing for the exam, please study very smartly, like which areas to concentrate, so that you can gain more number of marks in the exam, sir. Identify the structured mark by the arrow in the given image. In this given image, the arrow mark is present over here. I hope this is like an easy question to identify here. I have just included the histology slides a lot in this exam here. Why? Because many of the times the students will be actually having a problem with the histology, identifying the histological images and all. So just to make it easy for you people, so that you get some confidence over there. Now, now this cell which is actually marked here, you can clearly see that will be the goblet cells. The goblet cells. That will be stained very pale. Pale stained hota hai, and it is actually mucus filled. Because it is mucus filled over there, it will be palely stained there. That is a goblet cells which is actually marked here, sir. Which of the following statement about the internal capsule is incorrect? We need to find out the incorrect statement about the internal capsule. Now, another very, very important topic, internal capsule for your INI-CET exam. Let us discuss everything regarding this one here, sir. Now, in this diagram, you are able to see this one here will be the internal capsule here. First of all, remember that there are totally 5 parts in the internal capsule, sir. Now, those 5 parts here, number 1, there will be anterior limb, there will be posterior limb, the bent in the middle will be genu, and then there will be a retrolentiform part, and then there will be the sublentiform part here, sir. First point to remember here. Second point to remember here is about the relations. On the medial side, you will be able to see, yes, the head of the caudate nucleus here, and the thalamus over here, sir. And then on the lateral side, you'll be able to see the lentiform nucleus. And we know lentiform nucleus is made up of the putamen and the globus pallidus. Fine. So on the lateral side, there is lentiform nucleus, and on the medial side, we'll be having caudate nucleus and thalamus. If we learn a little bit in more depth, remember, this one here will be the anterior limb of the internal capsule. And the anterior limb of the internal capsule is between the caudate nucleus here and the lentiform nucleus here. Whereas this one here will be the posterior limb, and the posterior limb is between the thalamus on one side there and the lentiform nucleus on the other side. So we can learn in depth here, sir. Is it okay? Now, once you are done with the internal capsule parts as well as relation, now let us see the important structures which are going to pass through the internal capsule, sir. Number 1, this is the genu part here. This will be the anterior limb here, this is the genu here, and this is the posterior limb here, sir. Now, this one here will be the genu part here, sir. Now, what is going to pass from the genu part of the internal capsule? Now, please remember, from there you'll be having the corticonuclear tract. Which tract is going to pass from there? Corticonuclear tract is going to pass from the genu part. After that, in the posterior limb, remember, there will be corticospinal tract passing, that too from the anterior 2/3. Already this has been asked in your INI-CET exam only. So anterior 2/3 of the posterior limb, there will be corticospinal tract, pyramidal tract passing from here, sir. Fine. Now in this diagram, you're actually able to see here that there is a medial geniculate body here. There is a medial geniculate body here, and then there will be the lateral geniculate body here. And we know very well they are a part of your visual as well as the auditory pathway. M for music, M for medial geniculate body. So medial geniculate body will be a part of your auditory pathway. L for light, L for lateral geniculate body. That is a part of your visual pathway. Okay. That means whatever fibers are going to begin from the medial geniculate body, those are nothing but auditory radiations, and they are finally going to, yes, the auditory cortex. Auditory cortex, it is also referred to as Hessel's gyrus. Hessel's gyrus, yes, area number 41 and 42. Fine. And after that, the lateral geniculate body, L for light, L for lateral geniculate body. So it is a part of your visual pathway. So whatever radiations are coming from here, that will be optic radiation, and they will be going to the visual area, area number 17, 18 and 19. Okay, and you can clearly see in our diagram here, this auditory pathway, auditory radiation, the auditory radiation, they're actually going below the lentiform. So they are going to contribute to the, they are actually going to the sublentiform part. Okay, sublentiform part. Whereas the optic radiations are actually going behind that one. So that is why they are passing through the retrolentiform parts. So you got to remember all the tracts which are going to pass through the internal capsule here. Now, once you are done with this one, let us see all the statements one by one. Okay, let's see one by one here. Which of the following statement is incorrect? We need to identify the incorrect statement here. Genu of the internal capsule contains the corticobulbar fibers. Of course, this is a true statement here. Correct statement here. The posterior limb of the internal capsule contains corticospinal and thalamocortical fibers. Of course, that is also a true statement here. Anterior limb of the internal capsule lies between the caudate nucleus and the putamen on the other side. Of course, this is also a true statement here, sir. The lesion in the posterior limb results in ipsilateral hemiplegia. This is actually a false statement. That is wrong here, sir. This one is wrong here. Why? Because remember corticospinal tract. Corticospinal tract is also known as pyramidal tract. Pyramidal tract is going to descend down from that internal capsule, then the midbrain, pons, medulla, and in the lower medulla, the pyramidal tract fibers are going to cross. That is very famously referred to as pyramidal decussation, which will occur at lower medulla. Another hot favorite topic for your INI-CET exam. Many times you have asked the location of the pyramidal decussation. So if the pyramidal decussation is occurring at lower medulla, now here the lesion is in the internal capsule. So therefore what is going to happen? After descending down, it is going to cross and supply to the other side of the body. So it has to be contralateral hemiplegia. Why? Because injury to the pyramidal tract is before decussation. It has to be contralateral hemiplegia, not ipsilateral hemiplegia over there. So that's a false statement, and that is an incorrect statement, sir. That is an incorrect statement there, guys. I hope you're understanding here. So in this manner, we are done with internal capsule, the parts of the internal capsule, relations of that one, as well as all the tracts passing through the internal capsule. And one more thing, yes, of course, we have correlated that with the pyramidal decussation also. Okay, so in this manner, the questions can be asked. One more concept is completed here, sir. Moving ahead with the next one here. A newborn presents with fecal discharge from the umbilicus since birth. On examination, there is a patent connection between the ileum and the umbilicus. Which of the following embryological remnant is most likely responsible for this condition? And now, my dear friends, remember, suppose if this one here will be the embryo here. Okay. Now, this is the outer body wall of the embryo. And remember, the outer body wall of the embryo will be formed from your ectoderm. The endoderm is the one which is going to form the entire gut. So therefore, the foregut, midgut, and the hindgut, all this will be derived from endoderm. So basically, this one here will be the gut, and this gut is actually derived from endoderm here, sir. So this one here will be the foregut, this one here will be the midgut, and this one here will be the hindgut. The extension from the midgut here, this is vitello-intestinal duct or the vitelline duct. And from the hindgut, this extension here will be the allantois. That is allantois. Okay. Now, normally in normal healthy babies, what should happen? Normally, what should happen, sir? Vitello-intestinal duct has to be completely closed. It has to be gone. If it persists, if it remains, then what is going to happen? Yes, whatever the fecal discharge, that has to actually go out, but instead of that, it is going to come out from the umbilicus here, sir. Okay. In some of the exams, they have used the word as meconium also. Okay, so the meconium is actually going to come out of the umbilicus. Then the problem is with persistence of vitello-intestinal duct. The persistence of which duct here, sir? Vitelline duct. Are you understanding here? So if the vitelline duct is going to persist there, that will lead to what, guys? That will lead to the fecal discharge coming out from the umbilicus. That is important here. Now, sometimes what will happen, the entire vitello-intestinal duct is not persisting, sir. Only the proximal part is remaining. Can anyone answer me in the chat box over there? If only the proximal part of the vitello-intestinal duct is remaining, attached to the midgut, attached to the ileum part, then what is that condition referred to as? Only the proximal part of vitello-intestinal duct is persisting. Yes, of course. Very nice. Very nice. That is Meckel's diverticulum, sir. Yes, yes. Very good. That is Meckel's diverticulum. Perfectly correct, sir. Perfectly right. Acha, by the way, let me tell you like one more concept here itself, sir. One more concept here itself. Now, what is going to happen from this hindgut, whatever this extension is extending here, that is your allantois. Further, what is going to happen? The allantois is actually going to become urogenital sinus, urogenital sinus, and this cranial part of this one here will be the urachus. Normally, what should happen, sir? The urachus has to be closed, and the urachus will be actually closed to form median umbilical ligament. I'm telling you about the normal. The urachus is actually closed to form the median umbilical ligament. Perfect. And that you'll be able to observe at the apex of the urinary bladder. Why? Because urogenital sinus is the one which is going to become your urinary bladder, sir. So this is going to become the urinary bladder, and at the apex of that, this urachus will be closed to form the median umbilical ligament. Perfect. But in some unfortunate babies, what is going to happen? This urachus will not be closed. Therefore, what is going to happen here? The urine from the urinary bladder will be coming out from the umbilicus, sir. That condition is like weeping umbilicus. So this time, what is coming out from the umbilicus? That is urine. So when urine is coming out from the umbilicus, it is due to persistent urachus. Persistent urachus. That is also an important question here, sir. Yes, absolutely correct. Absolutely correct, Dr. Chauhan. Absolutely correct, Dr. Divine. Ajay Kumar, absolutely correct over there. So if the fecal discharge is coming from the umbilicus, then it will be due to persistent vital intestinal duct. If the urine is coming out from the umbilicus, and that will be actually due to the persistent urachus. Moving ahead, sir, with the next concept. Which ligament must be navigated carefully during distal pancreatectomy to avoid injury to the splenic artery? Now, my dear doctors, please look at this diagram here. In the abdomen topic, we have learned about the peritoneal folds in detail. When it comes to the peritoneal fold here, yes, in this diagram, you can clearly see this one is the liver here. Right in front of the liver, this ligament here will be the falciform ligament. Okay. Between the liver and the stomach here, this one here will be the lesser omentum. Lesser omentum. Okay. And please remember this very carefully here. This is the free margin of the lesser omentum. Lesser omentum where you have the portal triad. You can clearly see the portal triad there. There will be proper hepatic artery, portal vein, and the bile duct. Proper hepatic artery, the portal vein, and the bile duct in that free margin of the lesser omentum, where you'll be actually doing that Pringles maneuver. Okay. Then this one here will be the spleen, and between the stomach and the spleen here, sir. Between the stomach and the spleen here, this ligament here will be the gastrosplenic ligament. And finally here, between the spleen and the kidney here, this one will be the splenorenal ligament. Splenorenal ligament, or else we can also call this one as the lenorenal ligament. Now, if you're observing my diagram very carefully here, now from the celiac trunk, we know that there'll be like three important branches from the celiac trunk. One is the left gastric artery, another one will be the splenic artery, another one will be the common hepatic artery. Now, my dear doctors, try to identify this artery, the artery which is going to the spleen actually. The artery that is going towards the spleen here, that artery is nothing but the splenic artery. And splenic artery is going via which ligament here? Splenorenal ligament there. Now try to read the question, you'll be able to answer here. Which ligament must be navigated carefully during distal pancreatectomy? You know very well, pancreas will be having that head, body and tail, and the tail of the pancreas will be lying there in the hilum of the spleen. To avoid the injury to which artery? To avoid the injury to splenic artery, and we know very well it is going to pass through which ligament? Splenorenal ligament, which is also referred to as lenorenal ligament, sir. Are you understanding me? So splenorenal ligament or lenorenal ligament is having the splenic artery crystal clearly, you can see in our diagram here. And we have discussed about all the peritoneal folds, the rotation of gut, everything in detail in our videos there. So you can go and watch there. Perfect. Now, once you are done with this one here, let us go ahead with the next concept here. A 60-year-old male with the long-standing history of smoking presents with progressive hoarseness of the voice for the past 3 weeks. Chest CT shows a mass located in the aortopulmonary window. A mass in the aorticopulmonary window, adjacent to the arch of the aorta. Which of the following structure is most likely involved leading to his symptoms? Now, can you please recall a recurrent laryngeal nerve? Okay, recurrent laryngeal nerve. It is the one we are actually having like two of them, right and left one. Now, can you please try to recall out of the right and left recurrent laryngeal nerve, which is like more longer? The more longer one will be the left one. The left recurrent laryngeal nerve is more longer. Why? Because it is going to take a turn around the arch of aorta, whereas the right recurrent laryngeal nerve is going to turn around the right subclavian artery. Right subclavian artery here, sir. Okay. Of course, this diagram is much more clear here. So here you can clearly see here, this one here will be the left recurrent laryngeal nerve, which is going to take a turn around the arch of aorta over here. And this is the right recurrent laryngeal nerve, which is going to take a turn around the subclavian. Now they're telling that the mass is located over here, and it is of course going to compress which recurrent laryngeal nerve, sir? Of course, the left recurrent laryngeal nerve. Left recurrent laryngeal nerve will be compressed over there, leading to all those symptoms, signs and symptoms. But now, my dear friends, why I have given you this one here, nowadays in the exam, what is happening is, instead of just asking that, right and left recurrent laryngeal nerve, which is like more longer because of arch of aorta and all, they are giving the question in the form of like gross anatomy or clinical anatomy, but they are asking the answer in the form of embryology, sir. क्वेश्चन ग्रॉस वाला होगा, लेकिन आंसर वहां पर एम्ब्रियोलॉजी वाला होगा. ओके, तो मेरा सवाल यहां पर यह है, द लेफ्ट रिकरेंट लैरिंजियल नर्व इज लॉन्गर. It is because of which arch artery? The left recurrent laryngeal nerve is longer because of the which arch artery? I hope you have seen this diagram many a times. Development of arterial system. Development of the arterial system. Dr. Kishan Swami, absolutely correct. It is due to the left sixth arch artery. No, not the fourth one. Not the fourth one. No, fourth वाला नहीं, left sixth arch artery. I can prove that. Please look at this diagram here right now. इस diagram को देखो सर ध्यान से. Now, you know the arrangement of this diagram. I hope you have already learned about the development of arterial system. Otherwise, please, I'm requesting you go and watch the video. I've beautifully explained the formation of all the arteries. Okay, so in the front here, there'll be aortic sac. Behind, you'll be having the right and left dorsal aorta, and there'll be 6 arch arteries over here. Now, let us just slowly discuss here one by one. The first arch artery, what is going to happen to that one? It will degenerate, but there is a remnant of the first arch artery. Can anyone answer what is the remnant here, sir? What is the remnant of the first arch artery? Yes, of course, that is maxillary artery. Similarly, the second arch artery will also degenerate, but there is a remnant of that one, and the remnant will be stapedial artery and hyoid artery. So the remnant of the first arch artery will be the maxillary artery, and the remnant of the second arch artery here will be the stapedial artery, sir. Stapedial artery, as well as it will be the hyoid artery. Okay, these two are the remnant of second arch artery. Now, third arch artery is the one which is going to form, of course, the carotid arteries here, sir. You can see the common carotid artery, then it is giving a branch, it is external carotid artery, continuing as your internal carotid artery. What about the fourth arch artery? Remember, the left fourth arch artery is the one which is going to form arch of aorta, whereas the right fourth arch artery, it is the one which is going to form the right subclavian artery. You just have one arch of aorta towards the left, and the left fourth arch artery is going to form arch of aorta, and the right fourth arch artery, it is the one which is going to form right subclavian artery. And then we know this very well right from the first year MBBS days, that initially there will be totally 6 arches, pharyngeal arches. Out of the 6 arches, the 5th arch will degenerate. The 5th arch will degenerate. So remember from there, okay, nothing will be derived from the 5th arch. 5th arch से कोई artery यहाँ पर form नहीं होगी. Now welcome to the 6th arch. 6th arch is the one which is going to form pulmonary artery and pulmonary artery. So the right and left pulmonary artery. Be very careful. I'm telling pulmonary artery. Many of the students I have seen, they'll be just using the word loosely, like pulmonary trunk. It is pulmonary artery, sir. That is derived from the sixth arch artery. Now, between the pulmonary artery over here and the arch of aorta, there will be a duct here, and that duct will be the ductus arteriosus. Ductus arteriosus. Okay. Now, because that is present over there, that is why, my dear friends, hello, all my dear friends who are answering like fourth arch artery, no, that is not the right answer. Now learn it conceptually over here. Because of this, what is going to happen on the left side, the recurrent laryngeal nerve, which is coming from vagus, the recurrent laryngeal nerve cannot ascend up. वो ऊपर नहीं आ सकती है, इसीलिए वो वहीं पर stuck हो जाती है, and that is going to take a turn around the arch of aorta. That is why it is the longest one. But on the right side, do you have the ductus arteriosus here? Is there a ductus arteriosus present over here? No, that is not present over there. Anything coming from the fifth arch artery? No, nothing is coming from here. So therefore, what is going to happen? The right recurrent laryngeal nerve, ये ऊपर आ जाएगी. It is going to come up. And that is the reason why it is going to take a turn around the right subclavian artery. It is the one which is going to take a turn around the right subclavian artery. That's the reason why the right one is shorter, the left one is longer. I hope you're understanding this very well here. Okay, now in exam previously they used to ask the left one is longer because of arch of aorta, but nowadays they're asking because of which arch artery. Embryology question they're asking. So remember, it is longer due to the sixth arch artery. It is longer due to the left sixth arch artery. I hope the concept is like crystal clear. I hope you'll not make any mistake right now. Okay, चलिए सर आगे बढ़ते हैं. Okay, so once you are done with this concept here, let's move ahead now. All my dear friends, is this okay now? Thank you, Dr. Kartika. Thank you. A newborn baby presents with cyanosis and continuous murmur heard best at the left upper sternal border. Imaging reveals a patent ductus arteriosus. From which embryological structure this vessel is derived? Just now I told you, ductus arteriosus is derived from the sixth arch artery. Sorry, the sixth pharyngeal arch. So option D is the right answer here. It is derived from the sixth one, sir. So this development of arterial system is very much important. Just now I told you, ductus arteriosus will be derived from which one, sir? The left sixth arch artery, the distal part of this one. This year NEET question. Okay, nice. Whatever, sir. But remember, development of arterial system in the CVS embryology, cardiovascular system embryology, development of arterial system in the venous system, very much important for your INI-CET exam also. In INI-CET, there'll be questions coming from there. That is the reason why I have discussed the entire concept with you. I hope you have recalled that one, guys. Thank you, Dr. Verma. Thank you. Match the following joints with their corresponding type. चलिए सर थोड़ा सा ना अपने डिस्कशन को बैलेंस करते हैं. ओके ना. सो नाउ वी हैव डन अ एक्सटेंसिव कॉन्सेप्ट. Now about the joints. Of course, all the time there'll be one question coming from the joints in your exams. So elbow joint, of course, it is an example of your hinge joint. So one matches with B. So the one matches with B here, sir. Then after that, atlantoaxial joint here, sir. Atlantoaxial joint is nothing but that, pivot joint between the atlas and the axis, that will be the pivot joint over there. And then after that, the sternoclavicular joint here. So two matches with D here, sir. So one is going to match with B and then two matches with D there. Fine. Sternoclavicular joint will be an example of saddle joint here, sir. Sternoclavicular joint, one of the example of saddle joint there. And finally, yes, incudostopital joint, it is an example of your ball and socket joint. Four matches with C over there, sir. Now, whenever it comes to ball and socket joint, many of the students will be just remembering the shoulder joint and the hip joint, sir. Please forget that one. Examiner will never ask you. In our body, we are having like 4 ball and socket joints. Out of that, these two they will never ask, shoulder and hip joint. Another two they will be asking. One will be in the tarsal bone, talocalcaneonavicular joint. Okay, ball and socket, remember TCN, talocalcaneonavicular joint. And yes, of course, in between the incus and the stapedius, incudostapedial joints है. ये दो याद रखना बहुत important है. सवाल यहीं से आता है. Question will be coming from here. So in total, you remember there will be like 4 ball and socket joint. Please try to remember that one, sir. Next one. Which of the following is the primary efferent? Which of the following is the primary efferent neuron type that transmits signals from the cerebellar cortex to the deep cerebellar nuclei? Now, my dear doctors, welcome to another important concept of your exams. In INI-CET exam, many a times they'll be giving this picture of cerebellar cortex. I think you're able to identify. आपको याद हो गया इन cerebellum पक्का यहाँ से सवाल आता है और हमेशा वो लोग क्या करते हैं ना histology ये वाला diagram दिया जाता है सर. This diagram will be given. And always what happens, they'll be giving an arrow mark here like this. Identify this cells over there. And that will be the Purkinje cell, sir. है ना? But whatever, let us try to discuss the entire concept over here. In the cerebellar cortex, remember there will be totally like 3 layers. And out of the in these 3 layers, there are 5 different types of cells, sir. 5 types of cells. Remember the outermost layer here, this one will be the molecular layer. The middle layer here will be the Purkinje layer. And then finally this one here will be the granular layer, sir. The inner one will be the granular layer. So try to remember this one first. In the cerebellar cortex, you'll be having 3 layers: the molecular layer, the Purkinje layer, and the granular layer here, sir. Now in the molecular layer, you'll be having 2 types of cells. One will be the stellate cells, another one will be the basket cell. So you'll be having stellate cells, another one will be the basket cells, sir. In the Purkinje layer, there will be Purkinje cells. There will be Purkinje cells. And in the granular layer, you'll be having granular cells as well as the Golgi cells. Okay. So in the outermost layer, that is the molecular layer, you'll be having stellate and basket cell. And Purkinje layer, you'll be having Purkinje cells. And in the granular layer, you'll be having granular cells as well as the Golgi cells. Perfect. So as I told you, out of the 3 layers, you'll be having like 5 different types of cells. Now, if you observe them, out of all the cell, the largest one will be the Purkinje cell. And second point that you have to remember is that is flask shaped. They are like flask shaped, sir. These 2 points are done. Okay. So we are going to discuss like everything in this concept, sir. Please remember very, very carefully here. Okay. Now, out of all these neurons which are present in the cerebellar cortex, remember that the stellate cells are inhibitory, basket cells are inhibitory, Purkinje cells, they're also inhibitory, and then granular cells, Golgi cells are inhibitory. The only and only one which is excitatory will be the granular cells. The only one which is excitatory will be granular cells. So remember, cerebellar cortex is the largest collection of inhibitory neurons. All these neurons are inhibitory here. Okay, except the granular remaining. Yeah, granular will be actually the excitatory, remaining all will be the inhibitory. I hope the concept is clear. Now, one more question. Always in the exam, they're just putting an arrow mark at these cells and you have to identify. That is Purkinje cell. One more question is done here, sir. Now, my dear friends, what is the question asked here? Which of the following is the primary efferent from the cerebellar cortex? Now, please remember that if this one is your cerebral hemisphere and the midbrain and the pons and the medulla oblongata and the spinal cord here, sir. And behind here you'll be actually having the cerebellum. Now this cerebellum, it will be connected to the midbrain, superior cerebellar peduncle, and then here it is connected to pons with the help of middle cerebellar peduncle, and it is connected to the medulla oblongata with the help of inferior cerebellar peduncle. Fine. Now on the outer side here you'll be having cerebellar cortex. This entire thing will be the cerebellar cortex. Now the question here is that from the cerebellar cortex, which is the efferent? Remember, the answer here will be, it will be Purkinje cells. In the cerebellar cortex, the Purkinje cells will be giving the efferent here, and that will be going to the deep nuclei present here. And from the deep nuclei, it will be going out of the cerebellum. I'm just drawing a schematic diagram here. From the Purkinje cells, there will be efferent to deep nuclei, and from the deep nuclei, it will be efferent from the cerebellum itself. So in the exam, you should be very, very careful that if they are giving cerebellar cortex, if the question is cerebellar cortex, then the answer will be what, guys? The answer will be the Purkinje cells. Those will be the efferent from the cerebellar cortex, Purkinje cells. If they are not giving cerebellar cortex, if they're just giving the cerebellum, what is the efferent from the cerebellum, the complete cerebellum? Your answer has to be the deep nuclei. Your answer has to be the deep nuclei. So please be careful while reading the question in the exam. Efferent from the cerebellum, I repeat again, efferent from the entire cerebellum will be the deep nuclei, whereas the efferent from the cerebellar cortex will be the Purkinje cells. That is how you should be careful here. Okay. तो चलिए आगे बढ़ते हैं सर. Let's go ahead right now with the next question here. A neonate with hypotonia and poor feeding is found to have a genetic mutation affecting the cerebellar development. Again, one more question from cerebellum. Postmortem histology shows disruption of the cerebellar glomeruli architecture. Yeah. Cerebellar glomerular architecture. Which of the following is the location of the glomeruli? Okay. Now, my dear doctors, remember, for example, if this one here will be the cerebellar cortex. Just now I told you in the cerebellar cortex, there are like 3 layers. The outermost one is a molecular layer, which will be having stellate cells and the basket cells. It will be having the stellate cells and the basket cell. And the middle layer will be having Purkinje cells, and those Purkinje cells will be big, largest, and they'll be like flask shape. And they are going to send the dendrites over here. And then towards the deep nuclei, sir. That is your Purkinje cells. And then innermost layer you'll be having the granular cells, and then there will be the Golgi cells. Fine. Now I hope you all have heard about the mossy fibers and climbing fibers. They are actually the afferents, the one which are going to bring the information into the cerebellum. They are the afferent to the cerebellum, sir. Mossy fibers and the climbing fibers. Now out of those two, remember mossy fibers. Remember the mossy fibers, the one which are going to bring the information inside here. Now these mossy fibers are the one which are going only and only up to granular layer. It to which cells? Granular cells. Now whatever information they're going to bring in here, of course, that is the reason why I hope you remember I told you granular cells are excitatory, and they are going to carry that information all the way up to the outermost layer, that is the molecular layer over here. So, are you understanding me here? Now this structure which is actually formed here is referred to as the cerebellar glomeruli architecture. Cerebellar glomeruli. It is referred to as cerebellar glomeruli. Is it okay? So therefore, remember the correct answer here will be to which layer, guys? This architecture will be found in which layer? Of course, it is found in the granular layer. It is found in the innermost layer of the cerebellar cortex, that is granular layer. So here that the mossy fibers, they are going to bring it to the granular cells. There what is going to happen? Of course, the cerebellar glomeruli will be formed there, guys. So it is in which layer? Of course, the innermost layer, that is the granular layer, guys. Okay. So I hope this concept is also crystal clear right now. Now, after that, the next one, which of the following serves as the axis around which the midgut undergoes its characteristic 270-degree counterclockwise rotation during embryological development? Now, this is another important concept here, so about the rotation of gut. Before I teach you this entire concept here, can you please tell me here, will the foregut rotate or not, sir? Foregut rotate होता है कि नहीं होता है? Foregut rotate होता है कि नहीं होता है, sir? Of course, the foregut is going to rotate, and it will be rotating 90 degrees in clockwise direction. Okay. Then what about the midgut? Midgut rotate होता है कि नहीं होता है? Of course, ये भी होगा. And midgut is going to rotate 270 degrees in anti-clockwise direction, sir. Anti-clockwise direction. Whereas hindgut is not going to rotate, sir. Yes, foregut will rotate 90 degrees clockwise and midgut will rotate 270 degrees anti-clockwise. But hindgut is not going to rotate. Acha. In the rotation of midgut, what is going to happen? That is going to occur at around 6th week. At around 6th week, the embryo is very small. And when the embryo is like very small, what is going to happen? There is no enough space to accommodate the midgut here. The long coils of jejunum, the long coils of ileum, they are unable to accommodate here in the abdomen. And those coils will be actually coming out from the umbilical opening. So this midgut is going to actually come out via the umbilical opening here. So once it is going to come out of the umbilical opening here, what is going to happen? Then this midgut is going to actually rotate 270 degrees anti-clockwise. It is going to rotate anti-clockwise in 270 degrees, sir. Fine. But the question here is that it is going to rotate 270 degrees anti-clockwise around which axis? What is the axis here? The axis of rotation will be the artery. And we know very well what is the artery which will be supplying to midgut. It will be superior mesenteric artery. The artery of midgut will be the superior mesenteric artery. So midgut is going to rotate around which one, guys? Superior mesenteric artery. That is the right answer here. Perfectly done. Is it okay? And please remember, when this midgut is actually coming out, of course, can I call this one as hernia? Of course, we can call this a hernia, but remember this one will be the physiological hernia. So physiological hernia will occur at which week? Please remember, at 6th week, physiological hernia will occur. And then it is going to reduce back, sir. So it is going to reduce back into the abdomen by around 10th week. Okay, so the physiological hernia, it is going to come out by 6th week, and it is going to reduce back into the abdomen by 10th week. Now, thank God that you and me, we are like very much fortunate. Your midgut, my midgut, it came out, rotated, went back inside. Okay, so our midgut came out, rotated and went back inside. But some unfortunate babies, what is going to happen? The midgut will come out, but it is not able to reduce back into the abdomen. So if it is not able to reduce back into the abdomen there, then what is going to happen? The baby will take birth with the coils of intestines lying outside. That condition is referred to as omphalocele. Absolutely correct, Dr. Saab. Very nice, very nice. So failure of reduction of physiological hernia. अगर physiological hernia reduce नहीं होगा, then that condition is referred to as omphalocele. Omphalocele, sir. Then next, moving ahead. So another important concept has been revised here. Now, a 38-year-old man presents with decreased salivation from the parotid gland following a surgical procedure for temporomandibular joint dysfunction. On examination, he also reports altered sensation over the anterior auricle and temporal region. Okay. So basically, we are dealing with what here? There is an altered sensation over the anterior auricle over there as well as the temporal region here. Okay. And decreased salivation from the parotid gland. This all indicates that which nerve will be affected here. That is the auriculotemporal nerve will be affected, sir. ATN. Auriculotemporal nerve will be affected over here. Fine. So which of the following explains the functions of the affected nerve? Okay. Functions of the affected nerve. Now, first of all, let us try to recall the supply to parotid gland, my dear friends. Parotid gland will be actually supplied by ninth nerve. So the ninth cranial nerve, which is coming out from the medulla oblongata here. This is the ninth nerve here. And this ninth nerve will give rise to a branch, and this branch is referred to as Jacobson's nerve. Jacobson's nerve will be supplying to tympanic plexus. And from the tympanic plexus, what is going to happen? Another nerve is going to begin, that is lesser petrosal nerve. Lesser petrosal nerve, sir. And this lesser petrosal nerve will be finally going and ending in a ganglion. And it is going to end in a ganglion. That ganglion will be the otic ganglion. Now, when I'm telling you it is going and ending in the ganglion, that is otic ganglion, my dear doctors, I hope you have actually watched all my videos regarding the cranial nerves. I told you very clearly, if any nerve is going and ending in a ganglion, that nerve will be the functional nerve. That is a functional nerve. That nerve will be ending there. And from here, another nerve is going to carry the information. Now, which nerve is going to carry the information from here, from the otic ganglion? Of course, your phi 3. That is mandibular nerve. Mandibular nerve, which division? That is the posterior division of the mandibular nerve. And the very famous mnemonic, the posterior division will give rise to Ali branches, ALI. Auriculotemporal nerve, lingual nerve, and the inferior alveolar nerve, sir. Auriculotemporal nerve, lingual nerve, and inferior alveolar. Now, this auriculotemporal nerve, ATN, is the one which will be supplying to the skin over the auricle and the temporal region here. Okay. It will be supplying to the skin over the auricle, upper 2/3, as well as the temporal region here. Okay. It is also supplying to a joint, that is TMJ, temporomandibular joint here, as well as it is also supplying to parotid gland. That is the entire pathway, the secretomotor pathway of the parotid gland, sir. Secretomotor pathway of the parotid gland. And now what they're saying here, which nerve is gone? ATN is gone, sir. Auriculotemporal nerve is gone. So if you go through all these statements here, remember it is the one which is going to carry the general visceral efferent. General visceral efferent, GVE. It is the one which is concerned with supply to what's a glands. Okay, now, from the otic ganglion to the parotid gland, of course. When we learn about all that cranial nerve nuclei columns, GVA, SVA, GVA and all those things, I taught you very clearly, GVE is the one which is resembling or which is representing the parasympathetic nervous system. It is the one which will be having all those nuclei which are concerned with supply to the glands over there. So yes, of course, GVE to the gland, as well as general somatic. Somatic means what here? The body wall. Afferent, sir. Afferent means what here? It is going to sense from the face over there. So GSA column to the from the temporal region. So this is the right answer for the ATN, the fibers which it is going to carry, sir. So auriculotemporal nerve is supplying to the parotid gland. Supply to the parotid gland will be from the GVE column, general visceral efferent column. And yes, of course, the sensations from the body wall, the word referred to that will be somatic. So from the GSA, it will be referred. Yes, from the temporal region, it will be taken by the same nerve over here. I hope the concept is crystal clear here, sir. Next one, after completing this one here, sir, MRI coronal view of the knee joint with the 4 ligaments. The ligament label marked by the arrow prevents the anterior displacement of the tibia relative to the femur. Okay. And is commonly injured in the sports. Which ligament is marked here? You can clearly see in this diagram the arrow mark is over here. And of course the arrow mark is at the cruciate ligaments here. Cruciate ligament, from the name itself, we are able to understand they are crossing and they are going to maintain the anterior posterior movement of the, or limiting the anterior posterior movement of the tibia and the femur over there. Now it is also saying that it is most commonly injured in the sport over here. So the ligament which is actually marked here will be definitely the anterior cruciate ligament. Anterior cruciate ligament is the right answer here, sir. And remember, it is actually going to stabilize the knee joint. And yes, of course, it is going to stabilize the knee joint in anterior posterior direction over there, guys. So ACL is the right answer here. Moving ahead. During the liver cirrhosis, the type of the collagen fibers, abnormal collagen fibers, okay, is deposited. Which type of collagen forming reticular fibers primarily contributes to the scaffold around the hepatocytes and sinusoidal cells? Yes, can you answer this one here? Yes, yes, Kamlesh, absolutely correct. It is a part of your terrible triad. Yes, my dear doctors, which type of collagen will be deposited here in the liver cirrhosis? That is nothing but your type 3 collagen. It's a direct question over there. Type 3 collagen here, sir. Another important concept nowadays about the extravasation of urine, sir. 22-year-old male presents to the emergency department after a straddle injury. Can anyone tell me, before I teach you, in straddle injury, which urethra will be gone? Will it be membranous urethra or bulbar urethra? Come on, straddle injury will occur when a person is riding on a bicycle on a bumpy road. When a person riding on a bicycle on a bumpy road, sir. Very good, very nice. Okay. Examination reveals a tense, swollen scrotum and the lower abdominal wall also. Retrograde urethrogram confirms a rupture of the bulbar urethra. I told you, straddle injury, which urethra will be gone? Bulbar urethra. On further evaluation, it is noted that the urine has not extravasated into the ischiorectal fossa. Which anatomical structure prevents the spread of urine into the ischiorectal fossa? Now, my dear doctors, first of all, look at this diagram here. Now, in this diagram, you can clearly see this one here will be the bulbar urethra here, and that is ruptured in the straddle injury. Straddle injury, when the person is riding a bicycle on the bumpy road. So he'll be getting a hit in the perineum region, and of course the bulbar urethra will be ruptured. If this bulbar urethra is ruptured, the extravasation of urine will occur in, first let me tell you where it will occur. The extravasation of urine will occur into the superficial perineal pouch. And from here, the urine will also go into the scrotum. And from here, the urine will also go into the penile shaft. As well as, remember, the urine will also go into the anterior abdominal wall, sir. It is also going into the anterior abdominal wall. Oh my God. So if the bulbar urethra is ruptured over there, the urine is going to superficial perineal pouch, into the scrotum, into the penile shaft, as well as the anterior abdominal wall there. Okay. Now, it will not be going into the ischial rectal fossa. Why? Why? Because of the fascia present there. Which fascia? That will be the Colles fascia that will be present over there. So because of the Colles fascia, it is not going into the ischio-rectal fossa. Please remember that one, sir. Now, one more point to remember from here itself, my dear friends. Remember, this is the membranous urethra here. Now, this one here will be the membranous urethra. If this membranous urethra is ruptured over there, the urine will be extravasating out here. And that will be the deep perineal pouch. As well as the urine can also go into this space that is present behind that pubic symphysis around the neck of the urinary bladder and all. That space is known as space of Ridgius. So if membranous urethra is ruptured there, the urine is going into the deep perineal pouch as well as the space of Ridgius, and that will happen in the pelvic fracture. So please remember the two keywords there. If they are giving the keyword as pelvic fracture, membranous urethra will be gone. If they are giving the keyword as straddle injury, then bulbar urethra will be gone, sir. Bulbar urethra will be gone, guys. Okay. So please remember the concept in this manner here. Now moving on to the next concept here. Identify the structure labeled 2 in the histology of the bone here. In this diagram, the structure labeled 2 is actually here. This structure. Fine. Now, when you see in the histology of the bone, you'll be able to find that structure is nothing but your Haversian canal. What is that one? That is a Haversian canal, sir. That is actually representing that unit, important unit known as Haversian system. And there will be two Haversian canals. They'll be connected by that Workman's canal and all those things. But this one, which is represented by number 2 over there, will be the Haversian canal, sir. Moving ahead. A 22-year-old man presents to the dental clinic for extraction of his lower right third molar. During the procedure, he reports a sudden sharp pain despite the local anesthesia. Okay. After the extraction, he complains of numbness in the lower lip and chin on the right side. Okay. Which nerve is most likely injured during the procedure? Come on, sir. So in this one, first let me tell you why I have included this one here, sir. My sincere request to all my students here will be, please try to learn the mandibular nerve, sir. Mandibular nerve is extremely important for your INI-CET exam. 5-3 mandibular nerve is extremely important. Please learn that and go to the exam. Just now I gave you one question based on auriculotemporal nerve, Ali branches, posterior division. Now this question is actually based on the inferior alveolar nerve, guys. Inferior alveolar nerve. Please look at this diagram here. Now in this diagram, here is your trunk of the mandibular nerve. This one here is the trunk of the mandibular nerve. It is divided into two divisions, that is your anterior division and the posterior division. Posterior division will give rise to 3 branches. Number 1, this one here will be the auriculotemporal nerve, guys. This one here will be the auriculotemporal nerve. It will be actually going behind here like this one. And I told you very clearly what it is going to supply here. Apart from that, number 2, this branch here will be the lingual nerve, guys. This one here is the lingual nerve. And about the lingual nerve, for now, I want you to remember 2 points here. Number 1, the lingual nerve is going to pass through this ganglion here, and that ganglion will be the submandibular ganglion. Is it stopping there or passing there? It is passing. When it is passing from the ganglion, it means it is a topographical nerve. It is a topographical nerve, guys. Okay. And finally, you know very well, lingual nerve is the one which is going to carry the general sensation from the anterior 2/3 of the tongue. That is done. But the important point here is, here itself you will be actually having your submandibular gland, and the duct of that gland will be taking a turn. It is winding around that lingual nerve. Duct of the submandibular gland is winding around the lingual nerve. That is the reason why whenever you're going to remove that submandibular gland from there, most common nerve to be injured will be the lingual nerve, sir. The most common nerve to be injured here will be the lingual nerve. Now the third and final one will be ALI. I stands for inferior alveolar nerve. An inferior alveolar nerve, from the name itself we are able to understand that it will be going to the lower jaw, that is your mandible, and that is what is exactly given in this question over here. Yes, after the extraction of the tooth, what is going to happen? The person complains of numbness in the lower lip and the chin on the right side here. And that is because of which nerve over there? Yes, that is the inferior alveolar nerve, most likely injured here, guys. I hope the concept is clear now. So I request all of you to please learn mandibular nerve very well and go to the INI-CET exam, because many a time the questions will be coming from there, guys. Moving on to the next concept. Which of the following is a branch of the posterior division of internal iliac artery? We have discussed this in the pelvis and perineum topic. Please remember, common iliac artery here, that will be dividing into two branches, external and internal iliac artery here, sir. Now this internal iliac artery here will be in turn dividing into two division here, sir. This division here will be the anterior division and this division here will be the posterior division. And always I advise my student to remember the branches given by posterior division. There are only three branches. Remember that with the mnemonic as SIL. S for superior gluteal artery, I for iliolumbar artery, and L for lateral sacral artery. Yes, absolutely correct, Dr. Noor Sultan. Very nice. Whatever mnemonic you want to remember, you remember, but there are only three branches from there. That is your superior gluteal artery, iliolumbar artery, and then lateral sacral artery. And remaining all will be the branches from which division? Anterior division. Okay. Now in this question, they are asking which of the following is a branch of posterior division of the internal iliac artery. Of course, that will be the SIL branches. S stands for superior gluteal artery. That is the right answer here, sir. Are you all clear? So this concept is also done over here. Easy to remember. Just remember that three branches, remaining everything will be from the anterior division. That is at least, like, one of the best way to remember these branches, sir. The fontanelle marked usually closes around. Now this is the fontanelle which is marked here. That is your mastoid fontanelle. And mastoid fontanelle will be closed around 6 to 18 months of the birth. 6 to 18 months, somewhere around the 6 to 18 months, guys. A patient undergoes skull-base surgery and the surgeon identifies a foramen located between the sphenoid bone, temporal bone, and the occipital bone here posteriorly. Which of the following foramina is most likely being referred? Now, my dear friend, look at this diagram here. Now, in this diagram, somewhere here, this one will be the body of the sphenoid bone here, sir. Okay. That is the body of the sphenoid bone here. Or simply I'm writing S here for sphenoid bone, sir. And this one here will be the occipital bone here. And this one is the temporal bone here. Now between these three bones here, there will be a foramen present over here. And this foramen will be the foramen lacerum. What is that foramen? Lacerum. So that is also another important concept that you have to remember here, sir. And many times in your INI-CET exam, they'll be giving the questions from the cranial foramens and all. So one of the question I want you to remember is about the foramen lacerum here, sir. So it is present between the three bones. So actually what happens here, foramen lacerum is not a proper foramen here. It is a space which is left between the three bones here, sir. Okay, that is one thing. And in the options here, we are given with the foramen ovale also, guys. Can anyone tell me what are the structures passing from the foramen ovale? There is a mnemonic to remember there. It is male. Male. M stands for mandibular nerve. A stands for accessory meningeal artery. L stands for lesser petrosal nerve, and finally E stands for emissary veins. These are all the structures which are going to pass through the foramen ovale. And jugular foramen, what are the structures passing? Please remember this very well. Many a time the questions will be asked from here. Now from the jugular foramen, first of all, there will be a sinus passing here. This one will be the inferior petrosal sinus here. And after that, there will be the ninth nerve, glossopharyngeal nerve here. And then there will be 10th nerve, that is your vagus nerve here. And then finally, there will be the 11th nerve, that is your accessory nerve. And then there will be one more sinus passing from here, that is the sigmoid sinus. Please remember this small diagram. This will help you a lot, guys. Okay, the structures passing from jugular foramen will be the inferior petrosal sinus, 9th nerve, 10th nerve, and the 11th nerve. Now, out of these three nerves, can anyone tell me, my dear friends, which will be present in a separate sheath here? Out of the 9th, 10th, and 11th, which is present in a separate sheath here, sir? Remember the ninth nerve, very nice. Glossopharyngeal nerve will be separate sheath here, and 10th and 11th are present in the common sheath present over there. Perfectly right here. Okay. And finally, what is going to pass through the foramen spinosum here? Please remember middle meningeal artery. Extremely important, trending question nowadays. Why? Because if that middle meningeal artery is ruptured, it will lead to epidural hemorrhage. The middle meningeal artery is passing from which foramen? Foramen spinosum. So in that way, in this way, my dear friends, in this question, actually, I wanted my students to revise all about the foramen. All about the foramen. So which foramen is present between the three bones? That is foramen lacerum. Foramen lacerum is present between the three bones over there. Done. During laparoscopic cholecystectomy, the surgeon carefully identify Callet's triangle. Which structure does not form a boundary of the Callet's triangle? Come on, tell me. Which structure is not forming the boundary of the Callet's triangle? Please look at this diagram here. In this diagram, you are able to see the Callet's triangle. That is between, number one, the cystic artery here. Number two, the common hepatic duct here. And number three, the cystic duct here, sir. Okay, so please remember, the cystic duct, the common hepatic duct, and the cystic artery are the boundaries of Callet's triangle. Which does not form the boundary will be the inferior surface of the liver. Inferior surface of the liver, that is not going to form the boundary there, guys. Next one. During nephrectomy, the surgeon must avoid injury to ureter. Which of the following structure crosses anterior to the ureter in the abdomen? Anterior to the ureter. Not posterior, sir. It should be passing anterior. So if you see, the posterior abdominal wall is actually made up of psoas major muscle and then the quadratus lumborum muscle. They are present actually behind. Okay, so now let me show you one picture over here. In this diagram, you are able to see the ureter and the structures which are going to pass anterior to ureter, that is going to include the gonadal vessels over there. So remember, gonadal vessels are the one which are going to pass anterior to the ureter. Okay, so the relations of the ureters is very much important, sir. Fine. The relations of this one is given in this one, sir. Kamalesh, actually I'm telling from the Bailey's. Okay, Bailey surgery. Next one, sir. A full-term neonate is born with a large lobulated cystic mass protruding from the lower back region. Okay, near the coccyx. Any problem there? I hope it is clear. Yeah. A full-term neonate is born with a large lobulated cystic mass protruding from the lower back region near the coccyx. The mass is covered with skin and trans-elimination suggests that both cystic and solid component. There are no neurological deficits. MRI shows no extension into the spinal cord. Okay. Which of the following explains the origin of this tumor? First of all, can anyone identify the tumor and tell me what is the name of this tumor here? Come on. Can you please identify, can you please tell me which tumor are we speaking about here? Yes, of course, Dr. Manoj, Dr. Miguel, you're telling perfectly rightly there. That is sacrococcygeal teratoma. Sacrococcygeal teratoma. Okay. So it is near the coccyx there. That is a sacrococcygeal teratoma. And remember, the sacrococcygeal teratoma will be actually due to what? It is due to the primitive streak, the persistence of primitive streak here. The teratoma is actually the persistence of what, guys? The primitive streak there near the caudal end. Okay, next one, sir. In a patient with a submandibular gland stone, the surgeon must be cautious about which nerve as it loops under the duct. Just now I told you, submandibular gland, the duct of that is going to loop around which nerve? Lingual nerve. ALI, early branches, lingual nerve here, sir. That is the right answer here. Already I have explained you that in detail. But what I want you to remember is about this diagram here, sir. Many questions are coming from here also. Now in this diagram, what you have to remember is, this is your hyoid bone here. And from the hyoid bone, there is a muscle going into the tongue here. Of course, that muscle will be the hyoglossus muscle. Now we got to learn what are the structures going to pass superficial to that one and what are the structures passing deep to that one, sir. Superficial to that one and deep to that one. Okay. Now let us see one by one, or we'll do one thing here. I'll just mark here. You try to tell me what is the name. First, let us see what are the structures passing superficially. What is this nerve over here? Let us try to see the real-time exam over there. I'm just marking here and you try to answer there, guys. What is this nerve here? This nerve will be the lingual nerve. And this lingual nerve is passing through a ganglion here, and that ganglion will be the submandibular ganglion. Perfect. And after that, you're able to see that there is a muscle here. And this muscle starting from the styloid process, this is styloglossus muscle. And that is also going to pass superficial to the hyoglossus muscle. You can clearly see it's going superficial to this muscle hyoglossus. Then after that, you're able to see one more nerve over here, and this nerve will be the 12th nerve. That is your hypoglossal nerve. That is 12th nerve. It's going from below, and then finally it will be supplying to all the muscles of tongue. Hypoglossal nerve. Yes, of course, that is also going to pass superficial to that muscle. Okay, so these are all the structures going to pass superficial. Apart from that, you will also find the gland. Which gland here? Of course, the submandibular gland. And that submandibular gland actually has got like two parts. There'll be superficial part and there'll be a deep part. And that will be divided with the help of a muscle in the middle, that is mylohyoid muscle. Now from this diagram, we have removed that mylohyoid muscle. So this is which part here? Deep part of the submandibular gland. So therefore, here you'll also appreciate the submandibular gland. Which part here? Deep part. And that is all about the superficial relations of hyoglossus muscle. Superficial relations of hyoglossus muscle. In this diagram, yes, it is also showing not only the submandibular gland here, it is also showing the duct which is going to wind around that lingual nerve. Okay, so whenever you're going to remove that one, lingual nerve can be most commonly damaged. Done. So by this, we are done with all the relations of the hyoglossus muscle present superficially. चलो सर आगे बढ़ते हैं. Let us go to the next question right now. A 45-year-old man presents with difficulty in coordinating movements of his right arm, intention tremors, and then inability to perform the rapid alternative movements. MRI shows a lesion involving the superior cerebellar peduncle on the left side. Damage to this structure will be most directly disrupting the fibers that end in which of the following nuclei? Is it dentate nucleus, red nucleus, inferior olivary nucleus, and vestibular nucleus? Just now I told you that the cerebellum will be connected to midbrain, pons, and medulla oblongata with the help of cerebellar peduncle. Superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. Now here it is superior cerebellar peduncle. Okay. So remember this diagram here. In this diagram you can very clearly see, my dear friends, that this one here will be the dentate nucleus, and then the fastigial nucleus, and the interpositus nucleus, that is globose and emboliform nucleus. From here the fibers are passing, and these fibers are passing through this peduncle, and this peduncle here will be the superior cerebellar peduncle, and that is going to go and connect with what? Midbrain. And there, my dear friends, remember it is going to get attached to the thalamus. From the midbrain, through the midbrain, it is going and ending in thalamus, as well as the red nucleus present in the midbrain. तो red nucleus कहाँ पर होता है? Midbrain में होता है. Now if you correlate this entire concept, now you'll be able to understand, okay, the fibers are finally going to end in which nucleus here? The red nucleus. Okay. Fibers are going to end in which nucleus? In which of the following nucleus? Not like beginning. They're asking the ending there. Okay. So some of you are answering the option A there. Remember option A, it is actually the beginning. From the dentate nucleus, the fibers are going to begin. They are going to pass through the superior cerebellar peduncle, but it is going and ending in which nucleus? It is going and ending in the red nucleus. Okay, done. Dr. Ishan Joshi is asking like how many questions are left over there. I think Ishan Joshi, you have written the test. You know very well like how many questions were there in the test. The type of cartilage shown below is found in which of the following? First, you try to identify it is like which type of cartilage. We are having three categories of cartilage: hyaline, elastic, and fibrous cartilage. So there will be three types of cartilage. We'll be having hyaline cartilage, the elastic cartilage, and the fibrous cartilage. Hyaline cartilage, the word itself is telling hyalos. Hyalos, that means the matrix of that one will be completely like a glass, and the chondrocytes will be actually in the form of groups here, sir. The chondrocytes are in the form of groups, and the matrix will be like glass, like it is hyaline. Okay. In the elastic cartilage, what is going to happen? Again, the chondrocytes will be in groups only, sir. But in the middle of that one, you'll be able to appreciate the elastic fibers. Fine. And finally, in the fibrocartilage, what is going to happen? Of course, you'll be having type 1 collagen in the long wavy bundle fiber. And the chondrocytes are actually arranged in the form of rows here, sir. They are arranged in the form of the rows. Okay. Now, once you have revised this one here, first of all, you try to identify this picture. It is which cartilage? Remember, this one here will be the elastic cartilage here, sir. Now, if this one here will be the elastic cartilage here, what will be the examples of this one? Where exactly it is present over here? So, of course, apex of the arytenoid cartilage will be having elastic cartilage in that one. Base of the arytenoid cartilage will be having hyaline, but the apex of that one will be the elastic cartilage, sir. Cricoid cartilage, no, it will be an example of hyaline cartilage. Epiphyseal plate, of course, the epiphyseal plate of the cartilage between the epiphysis and diaphysis, that is an example of hyaline cartilage. So it is also not the example here. Epiglottis is an elastic cartilage here, and even the pinna, the auricle here will be the elastic cartilage. Intervertebral disc is not the elastic cartilage over there. So therefore, option A, option D, and E, this will be the elastic cartilage. So correct answer is option D here, sir. So basically, you should be able to identify the cartilage, sir. In INI-CET exam, many of the time the questions will be coming from the epithelium examples as well as the cartilage examples also. So you got to remember, you should be able to identify the cartilage as well as you should be able to remember the examples here, sir. Now moving ahead. A 10-year-old boy is recovering from viral encephalitis. In the affected areas of the brain, the resident phagocytic cells known as microglial cells are activated. Now, these cells originate from which embryonic layer? Can you please answer me here? Neural crest cells, neuroectoderm, mesoderm, or surface ectoderm? Come on. Dr. Chauhan, yes, of course, that is elastic cartilage. No, you can actually see the chondrocytes first of all. They are in the groups over there. Apart from that, yes, of course, in the matrix, if you see, it is not like glass. There you'll be actually having the elastic fibers there. The elastic fibers will be like numerous and branched there. Yes, of course, the microglial cells are derived from where? From the mesoderm, sir. That is the right answer here. Very good, Dr. Swikar. Very good. It is from the mesoderm. Very nice. Moving ahead. Which structure forms the roof of the inferior horn of the lateral ventricle? Okay. This one here will be the cerebral hemisphere. Now, in the cerebral hemisphere, remember, telencephalon will be having the lateral ventricle. And lateral ventricle will be having anterior horn. There will be a body. And then the posterior horn. And then there will be inferior horn, sir. So, this one here will be the anterior horn. This one here will be the posterior horn into the occipital lobe here, and this will be the inferior horn into the temporal lobe. Now they are asking here, what is going to form the roof of this one? Just remember one diagram here, I'll tell you. There will be a caudate nucleus present here. The C-shaped or comma-shaped caudate nucleus will be present over here like this. That's all, you're done. The C-shaped or the comma-shaped, the caudate nucleus is also present inside that one, sir, the lateral ventricle. Okay. So therefore, if this is the inferior horn, what is going to form the roof of the inferior horn, sir? The roof of the inferior horn is formed by the tail of the caudate nucleus. That is the right answer here. So if you remember my one diagram here, it will be damn easy for you. चलिए सर आगे बढ़ते हैं. Which of the following statement about the papillae of the tongue is correct? Already we have discussed about the papillae of the tongue in the very beginning of the session. I hope now at least you'll be able to answer me here, sir. Okay, come on. Filiform papillae are keratinized and lack the taste buds. I told you both the points in the very beginning only. है ना? Filiform papillae are the one, yes, which will be not having the taste buds, sir, and they'll be having the keratinized stratified squamous epithelium. So this is actually a true statement here. Fungiform papillae are supplied by glossopharyngeal nerve for the taste. No, circumvallate papillae is supplied by, glossopharyngeal nerve for the taste, sir. So this is actually a false statement here. And then circumvallate papillae in front of the sulcus terminalis and are supplied by chorda tympani nerve for the taste. No, 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 no. This is also a false statement. Why? Because circumvallate papillae are supplied by ninth nerve, glossopharyngeal nerve, not the seventh one. Foliate papillae are lined by non-keratinized epithelium and have the taste bud. This is also a true statement here. So the true statement here will be the A and D. So therefore option C will be the right answer here. Perfect. Already we have discussed in detail about all the papillae present in the tongue in the very beginning itself. Okay, तो चलिए आगे बढ़ते हैं. A researcher is studying the trigeminal sensory system. Which of the following statements are correct for the trigeminal sensory system? Can anyone answer me here? In total, how many trigeminal nuclei do you have, sir? In total, how many trigeminal nuclei do we have? Remember, in total, there will be 4 trigeminal nuclei. And out of the 4 trigeminal nuclei, there will be 3 sensory and 1 motor. Be careful here, sir. Try to learn it properly. They're not 3, they're totally 4 there. Out of the 4 of them, 3 will be sensory and 1 will be motor. Now, where exactly this trigeminal nuclei will be located? They'll be located in the brain stem. तो आप ऐसे मान लो कि ये मिड ब्रेन है और फिर ये वाला पॉन्स होगा और फिर ये वाला मेड्यूला होगा और फिर यहाँ पर ये वाला स्पाइनल कॉर्ड होगा, सर. बेसिकली आई एम टेलिंग यू दिस इज द ब्रेन स्टेम. Okay, so this one here will be the midbrain. This is the midbrain here, and this one here will be the pons, as well as this one here will be the medulla oblongata. Now, the trigeminal sensory nuclei. Sensory nucleus of trigeminal, it's such a huge nucleus, such a big nucleus. It is present throughout the brainstem. I mean to say it is present in midbrain, as well as it is present in the pons, as well as in the medulla oblongata, and from here it is going all the way up to the spinal cord also. And if you want to remember that it is going up to which level in the spinal cord? Up to the level of C2, the second cervical segment, sir. Now this first nucleus which is present here will be in the midbrain. Midbrain is also known as mesencephalon, so therefore it is mesencephalic nucleus. The second one present in the pons here, this one here will be the chief sensory nucleus or the principal sensory nucleus. And the third one present in the medulla oblongata and going into the spinal cord also. So therefore this one is the spinal nucleus. Okay, fine. And we know very well trigeminal nerve is the one which is going to carry the sensations from your face here, sir. From the face, the sensory supplies by trigeminal nerve. So it is the one which is going to carry everything from the face like pain, temperature, touch, pressure and all. But आपको यहाँ पर in depth पढ़ना होगा कि which sensation is exactly going to which nucleus. So my dear doctors, please remember that spinal nucleus is the one which is going to receive the pain and temperature from the face. So pain and temperature from the face is going to which nucleus? Spinal nucleus. The chief sensory nucleus is the one which is going to receive the touch and pressure from the face. Touch and pressure from the face. And this is also already asked in your INI-CET exam. Please remember that the proprioception from the face is received by the mesencephalic nucleus. Already question पूछा गया था, sir. Is it okay? Are you all understanding, my dear friends? So pain and temperature will be carried to the spinal nucleus, touch and pressure will be carried to the chief sensory nucleus, and proprioception will be carried to the mesencephalic nucleus. That is about the sensory wala. And of course, the motor nucleus is only one, and that will be located in the pons here, sir. I'm just writing M for this one here. That is a motor nucleus. Okay. So let us see all the statements right now. The trigeminal ganglion contains the cell bodies of the primary sensory neurons. Okay. So basically we need to find out correct or incorrect statement. Correct statement here, sir. Okay. The trigeminal ganglion contains the cell bodies of the primary sensory neurons. Dr. Kamlesh is telling it is very high yield here. Okay. Yes, of course, it will be having the primary sensory neurons over there. The mesencephalic nucleus of the fifth nerve, trigeminal nerve, is involved in proprioception from the muscles of mastication. Absolutely, this is also a correct statement here. The principal sensory nucleus in the pons process pain and temperature. No, this is wrong one here. Pain and temperature is not by the principal sensory nucleus, it is by spinal nucleus. The spinal sensory nucleus of trigeminal extends into the upper cervical spinal cord. Yes, of course, up to the C2. So option A, option B and option D will be correct here, sir. So A, B, D is the correct statement here. A, B, D. Yes, is the right answer. Are you all done? Chalo, perfectly done here, sir. We are done with this question also here. Now moving ahead, all of the following muscles are supplied by the medial plantar nerve, except which one? Come on. Now medial plantar nerve ये कहाँ से आता है, sir? Please remember that. Suppose if this is your foot here, if this is the foot here, this is the plantar surface, and this is the surface which we are seeing from above, that is the dorsum of the foot. Now the nerve which is going to come from behind, that will be the tibial nerve. Tibial nerve will take a turn and enter into the foot and divide into two branches. One is medial plantar, another one is the lateral plantar nerve. Medial plantar and lateral plantar nerve, sir. And this medial and lateral plantar nerve are going to supply to all the muscles of foot, sir. All the muscles of foot. They are taken care by the medial plantar and lateral plantar. And our question here is that all of the following muscles are supplied by medial plantar nerve, except which one here? Except which one here, sir? Now when you learn about the muscles of foot, remember all the muscles of foot are actually arranged in 4 layers, sir. Like from below here, there'll be like first layer. If you remove that, you'll be able to see second layer. And then if you remove that, you'll be able to see third layer and the fourth layer. Now in the very first layer, you'll be actually having the flexor digitorum brevis muscle in the middle here. But on either side, you'll be actually able to see the abductor. Abductor hallucis here, and there'll be abductor digiti minima here. Now, actually when you go and watch my regular videos, I'm telling you, I have given you a simple method there. The best way to learn this one is compare the muscles of hand with the muscles of foot, sir. In the hand, all these muscles are supplied by ulnar nerve and the median nerve here. Ulnar nerve and the median nerve here. Now just make your hand like a foot here. So what is going to happen? Ulnar is going to correspond to what? Ulnar is going to correspond to the, yes, lateral plantar here. And median nerve is the one which is going to correspond to what, sir? The medial plantar nerve. So what you have to do is the lateral and medial plantar nerve, the best way to learn is, yes, always learn upper limb and lower limb in a comparative manner here, sir. That will make your life very much easier. तो अगर आप ऐसे पढ़ोगे तो yes, of course, now you can see here, flexor digitorum brevis will be supplied by medial plantar nerve, whereas the abductor digiti minimi means it will be present towards which side? Lateral side, and that has to be supplied by the lateral plantar nerve. Whereas abductor hallucis will be supplied by the medial plantar nerve. That is about the first layer. So in first layer, you basically remember there are abductors present over there. अगर आप इसको remove कर दोगे, then welcome to the second layer. In second layer, there are 2 muscles and 2 tendons. There are 2 muscles and there'll be like 2 tendons here, sir. Now, which 2 muscles that you have here in the second layer, my dear friend? Remember, you'll be actually having the quadratus plantae here. This one, quadratus plantae muscle over here. That will be supplied by the lateral plantar nerve. And yes, of course, you'll be having the lumbricals here in the second layer. And out of the lumbrical, remember, lumbrical number 1 will be supplied by the medial plantar nerve, whereas lumbrical number 2, 3, and 4 will be supplied by the lateral plantar nerve. Okay. If you remove them, welcome to third layer. Third layer में होते हैं flexors. So there will be flexor hallucis brevis, and there will be flexor digiti minima here. This is supplied by the lateral plantar, which is corresponding to your ulnar nerve, and the flexor hallucis here, that will be supplied by medial plantar, which is corresponding to what's the median nerve. In that way you can remember. And then yes, the adductor hallucis. Now please pay attention here. Why? Because in the muscles of hand also, remember, the adductor pollicis will be supplied by ulnar nerve. I told you in the very first question, The very first concept that we have learned, sir. So ulnar nerve is going on the other side and supplying to the adductor pollicis is there, and here in the foot the adductor hallucis will be supplied by the corresponding one, that is lateral plantar nerve, sir. Make sense? And finally, in the fourth layer, you'll be just having the, yes, interossei, the palmar interossei and the dorsal interossei. And always, always, I'll be telling in the class that all the interossei will be supplied by which nerve? Ulnar nerve. All the interossei will be supplied by ulnar nerve. So therefore, ulnar nerve is corresponding to which nerve in the foot there? Lateral plantar nerve. So therefore, just make your hand like a foot. The things will become damn easy for you, sir. Damn easy. So all of them will be supplied by lateral plantar nerve. Understanding? Now, if you observe all the options over here, remember all of the following muscles are supplied by medial plantar nerve. अभी जो हमने देखा है, except for what? Except for the adductor hallucis here, sir. That will be supplied by lateral plantar nerve, sir. In that way, you can easily actually, practice and remember about the muscles of foot, which are actually arranged in all the 4 layers over here, sir. In omphalocele, the layers covering the herniated viscera from outside to inside are. अभी मैंने आपको पढ़ाया था, physiological hernia will occur during the 6th week and that has to reduce back by 10th week. If it doesn't reduce back, it will be known as omphalocele. Okay, now in this condition, what is going to happen here? This, the baby will be born with all that coils of intestines lying outside only, and of course that will be covered by this sac. Okay, why? Because when the loops of the intestines are going to come out, they are actually covered by the sac. So now they are asking like, what are all the layers present outside to inside? So outside, first of all, you'll be having amnion, and then there will be Wharton's jelly present over there, and then inside will be having the peritoneum. Option C will be the right answer here, sir. First, outside there will be amnion, then you'll be having the Wharton's jelly, and then there will be the peritoneum present over there. Fine. Next one, sir. Which of the following structures are lined by simple columnar epithelium with microvilli? With microvilli. I hope you remember in the histology when we learned, I told you about all the epithelium in a crystal clear manner, and then additionally, yes, there will be certain surface projections from the cells like cilia and the microvilli and all. So which cells will be actually having microvilli on their surface? That is the small intestine, number 1 here, and the gallbladder. Why do you have that microvilli? To increase the surface area for absorption. And in the gallbladder, what is going to happen? Bile will be collected and it will be actually concentrated over there. So for increasing the surface area of absorption, yes, in the small intestine and in the gallbladder, you will be having the cells with the microvilli over there. So now let us see here. Small intestine will be including duodenum, yes, of course, as well as gallbladder. They are the one which will be actually having the simple columnar epithelium cells with the microvilli. Option A and B are correct over there, not in the ureter and trachea. Ureter trachea में तो वहाँ पर नहीं होता है. In the trachea, you'll be actually having that characteristic respiratory system वाला epithelium. Okay, pseudo stratified columnar epithelium with the cilia there, है ना? Ciliated pseudo stratified होता है वहाँ पर, columnar नहीं होता है ना? चलिए सर आगे बढ़ते हैं. Which of the following correctly matches the site of aneurysm with its most likely clinical finding? I think you're understanding, my dear friends. Don't try to just see the answers here. When you are actually solving along with me, concepts are very much important. And apart from that, remember, don't try to solve just the answers and all and leave it so. What I'm trying to tell you is that whatever test that you have, we have actually conducted here, and whatever questions I'm showing you here, okay. When I'm telling you one of the question regarding epithelium topic is very much important to be revised for your INICET exam. Joints topic is very much important to revise. Apart from that, in the histology, cartilage, at least you look at the cartilages and go. Hyaline, elastic, and fibrous cartilage. Definitely the question will come. Mandibular nerve is very much important. Muscles of mastication, they'll be asking a question from there. Okay. About the foregut rotation, midgut rotation, they'll be asking the questions about that one. So please remember all these concepts. Concepts are very much important here, sir. Okay. Dr. Suvikar is telling ureter transitional epithelium. Yes, of course, transitional epithelium, urothelium will be present over there, sir. Okay. Mayank Jain, thank you. Which of the following correctly matches the site of aneurysm with its most likely clinical finding? Okay. When you learn about the circle of Willis, absolutely correct, sir. Absolutely correct. Yes, of course, you are correctly answering there. In the circle of Willis, you'll be able to see the anterior cerebral artery on one side and the anterior cerebral artery on the other side, and they are connected by anterior communicating artery. And in that anterior communicating artery, if there is aneurysm formed there, of course it is going to compress what here? It is very much nearer to optic chiasma. So therefore, what is going to happen? It will lead to bitemporal hemianopia. So the correct answer here will be the anterior communicating artery, bitemporal hemianopia. Which of the following statement is true about the anatomy of breast? Okay, let's see which is the true statement here, sir. The axillary tail of Spence passes through the clavipectoral fascia into the axilla. Absolutely wrong. No. Clavipectoral fascia is not pierced by the axillary tail of Spence. Perfectly right. Majority of the lymph from the breast drains into the posterior group of axillary lymph nodes. Is it posterior or anterior? Come on, come on, come on. We are almost done, sir. Come on. Thank you, Dr. Ricky. Majority of the lymph from the breast is draining into the posterior group or the anterior group of the axilla? Anterior. So this statement is also wrong. The nipple is usually situated at the level of fourth intercostal space. Yes, of course, it is correct. The lactiferous ducts open independently onto the summit of the nipple. Yes, of course, they are opening independently. So option C and option D are correct here. So therefore, D is the right answer here, sir. Okay. Very nice, Dr. Krish. Very nice, Dr. Rahul. Very nice, Dr. Abhishek Kumar. चलिए सर आगे बढ़ते हैं. Which of the following is not a tributary of the inferior vena cava? Now I'll give you a simple diagram here, so follow this one. Your life will become easy for you. अगर मान लो कि ये diaphragm है, if this is the diaphragm here, sir, and then this one here will be your inferior vena cava here. We know very well that inferior vena cava is formed by the union of common iliac veins. Okay. Can anyone tell me common iliac veins will combine to form inferior vena cava at which level? Common iliac veins will combine to form inferior vena cava at which level? Come on, answer me. Remember, it will be at the level of, I'm seeing the chat box here. L3, 10, oh my god. Remember, yes, inferior vena cava will be formed at the level of L5, sir. Even this was also asked in one of the exams. Remember that one, sir. Now you might be thinking like, why is like Azam sir stressing on this point here? इसमें क्या होता है ना, स्टूडेंट्स मिस्टेक कहाँ करते हैं मैं आपको बताता हूँ. वी शुड ऑलवेज लर्न विद अदर्स मिस्टेक्स सर. दूसरों की गलतियों से हमको ना सीखना चाहिए. अब स्टूडेंट्स क्या करते हैं ना, उनको अगर याद नहीं आता है तो क्या करते हैं, दे विल ट्राई टू रिकॉल abdominal aorta. Abdominal aorta is going down from T12, L1, L2, L3, L4. At L4 it is going to divide into the common iliac artery. अब ये कॉमन सेंस लगाते हैं कि अच्छा abdominal aorta अगर L4 तक होगा तो inferior vena cava भी तो वहीं पर फॉर्म होता है ना. वो बाहुबली टाइप पिक्चर होता है ना कि आर्टरी आयोटा एंड वेना कावा दोनों साथ में होते हैं. तो वो सोचते हैं कि यहाँ पर ये भी वहीं पर L4 पर फॉर्म हो रहा है. लेकिन याद रखिए inferior vena cava L5 पर फॉर्म हो रहा है, नॉट L4. अब ये ऊपर जाएगा इनटू डायाफ्राम अप टू विच ओपनिंग? ऑफ कोर्स द वेना केवल ओपनिंग. तो वेना केवल ओपनिंग किस लेवल पर होती है सर? दैट विल बी एट द लेवल ऑफ T8. दैट विल बी एट द लेवल ऑफ T8 सर. आर यू क्लियर विद दिस वन हियर? और ये कहाँ से याद करेंगे हम? वी आर गोइंग टू रिकॉल विद दैट निमोनिक वॉइस ऑफ अमेरिका, T8, T10 एंड देन T12. तो इस तरीके से याद रख लो कि इंफीरियर वेना कावा इज गोइंग टू एक्सटेंड फ्रॉम वेयर टू वेयर. दैट इज क्रिस्टल क्लियर. Now, once you are done with this one here, remember what are the tributaries here, sir. Number one, there will be right gonadal vein that is going to drain into the inferior vena cava. Number two, there will be like lumbar veins present over here, sir. That is also going to drain into the inferior vena cava. And then मान लो कि यहाँ पर ये kidney है और यहाँ पर ये kidney है. So there will be the renal vein and the renal vein here, sir. So renal veins are also going to drain into the inferior vena cava. Above the kidney, there will be suprarenal gland. only the right suprarenal vein is going to drain into the inferior vena cava. And after that, liver. From here, hepatic veins. Hepatic veins are also going to drain into the inferior vena cava. And then finally, from the diaphragm, what is going to happen? There will be inferior phrenic vein. Inferior phrenic vein is also going to drain into inferior vena cava. So just to remember my diagram here, sir, you'll be easily able to remember all the tributaries of inferior vena cava here, sir. Instead of just making some mnemonic A, B, C, D and all, this is the best one, guys. Okay. Now, right suprarenal vein and the right gonadal vein draining into inferior vena cava. Sir, what about the left one? The left gonadal and the left suprarenal, both of them will be draining the blood into left renal. The left gonadal and the left suprarenal, both of them are going to drain into the left renal one, sir. Are you understanding here? So therefore, which of the following is not a tributary of inferior vena cava? The correct answer here will be the left suprarenal vein. Option D is the right answer here, sir. Koi dikkat? Any problem here, guys? Inferior phrenic vein will be draining into inferior vena cava. Right suprarenal, right gonadal will also drain into inferior, but the left one will drain into the left renal vein. Okay, चलो जी आगे बढ़ते हैं. Where is the SRY gene located on the Y chromosome? Now this one here will be the Y chromosome. SRY gene will be located on short arm, and that to the distal part of this one here. That to the distal part of that one here. Okay, so the correct answer here is the distal end of the short arm here. Now the next one. Arrange the following cells from the lumen towards the basal lamina. Okay. Spermatogonia, spermatozoa, primary spermatocyte, spermatid and myofibroblast. पहले तो मैं आपको बता दूं कि in the males, the male gonads testis, inside the testis will be having many lobules, and inside those lobules will be having highly convoluted tubule known as seminiferous tubule, sir. Now when you see inside the seminiferous tubule, there will be the germ cells here, and in the middle you'll be having the Sertoli cells. And already this image based question has been given, sir. This is how the Sertoli cells will be looking inside the lumen of the seminiferous tubule. Now, whatever developmental stages are there in the spermatogenesis, in the formation of the spermatozoa, all of that is actually happening in the membrane of the Sertoli cell, sir. Now, what is going to happen in the membrane of the Sertoli cell? You'll be able to find the pouches over there in which you'll be actually having all the developmental stages one by one. So first you'll be having below there spermatogonium hota hai. Then after that you'll be having primary spermatocyte, then the secondary spermatocyte, then the spermatid, and then finally you'll be having the spermatozoa at the tip here. At the tip means that is towards which side, sir? Towards the lumen side. Towards the lumen side. लेकिन यहाँ पर आपके क्वेश्चन में क्या पूछा जा रहा है? It is actually in the reverse here. From the lumen towards the basal lamina. हमको उल्टा आना होगा. हमको यहाँ पर से ना उल्टा आना होगा वापस. ओके, तो सबसे पहले ल्यूमन की तरफ में क्या होगा? स्पर्मेटोजोआ होगा. दिस इज द फर्स्ट वन प्रेजेंट देयर, सर. सो नंबर 2 शुड बी द फर्स्ट वन. तो ये रूल आउट हो गया. दिस ऑप्शन इज रूल्ड आउट. दिस ऑप्शन इज रूल्ड आउट, सर. And after that, whatever is given here in this, it should be spermatid. Why? Because spermatid will undergo structural changes to form the spermatozoa. So after 2, the next one has to be the 4. So I think option A is the right answer here, because after 2 it has to be the 4. And then there will be the primary spermatocyte. Primary spermatocyte to secondary spermatocyte to spermatid. Hai na? So then next is spermatocyte. Then of course that is coming from spermatogonium cells, and then the myofibroblast. That is the right arrangement. Okay. So I have included this question here. Why? Because many times, many questions will come in your INI-CET exam from the gametogenesis also. Gametogenesis also, many times the questions is coming, sir. And yes, of course, they have also given an image-based question based on the Sertoli cells over here. So that is also very much important here. Which of the following statement regarding the facial artery are correct? It arises from the external carotid artery. We need to discuss about the facial artery now. It arises from the external carotid artery and crosses the mandible anterior to masseter. Absolutely correct statement here. Why? Because the facial artery is the one which is going to begin from external carotid artery. It is one of the branch of that one. Then it is going to cross the mandible in the antero-inferior border of masseter. Antero-inferior border of masseter. Perfectly correct, sir. The angular artery is the terminal branch that anastomoses with the branch from the internal carotid artery. ये भी बिल्कुल सही है. The facial artery is going obliquely in the face here. And while going obliquely in the face, it will be giving like 4 branches. To the lower lip, inferior labial artery. Upper lip, superior labial artery. Lateral wall of the nose, lateral nasal branches. And finally near the medial angle of the eye, angular branch. And that angular branch is going to form anastomosis with internal carotid artery. One of the branch of that one, which is nothing but the dorsal nasal branch. Dorsal nasal branch, which is coming from ophthalmic and then internal carotid, sir. So perfectly correct. It gives off ascending palatine artery which supplies the soft palate and tonsil. ये भी बिल्कुल सही है. Facial artery will give 4 branches here in the face. Okay, inferior labial, superior labial, lateral nasal, angular. But also giving 4 branches in the neck. In our regular classes, I gave you the mnemonic as STAG. You can go back and watch the videos. In the videos I told you stack. Okay, so there will be submental artery here, T for tonsillar artery, A for ascending palatine artery, and G for glandular. The ascending palatine artery, yes, it is going to supply to soft palate and tonsils. The artery lies superficial to the platysma muscle in the neck region. No, this is absolutely wrong. It is not superficially present. The internal carotid artery gives off branches that directly supply the face. No. Internal carotid artery is not giving any branches which are directly supplying the face. So therefore, the correct answer here will be A, B, C. Where are the options here? These statements will be the right one here, sir. A patient complains of numbness and weakness in the first dorsal web space of the foot. Which nerve primarily supplies the sensation to this area? Now, look at this diagram here. In this diagram, this one is the plantar surface. ऑलरेडी मैंने आपको बता रखा है कि टिबियल नर्व यहाँ पर टर्न होती है और डिवाइड होती है लेटरल प्लांटार और मीडियल प्लांटार नर्व में. तो टिबियल नर्व इज सप्लाइंग टू द स्किन नियर द heel region here, whereas lateral plantar nerve will be supplying to the lateral 1.5 digit here, sir, on the lateral side, whereas medial plantar nerve is supplying to 1, 2, 3.5 medial 3.5 digit, and that is happening where? On the plantar surface. Now let us see the dorsum here. Now here, this is the first toe and the second toe here, sir. The first toe, the great toe and the second toe here. Now the skin in the cleft of first toe and second toe. Now the skin in the cleft of first toe and second toe. This one here, sir. ये वाला part, जो yellow color highlighted है. And that is also referred to as first web space. The space between the digits will be web space. So that is first web space. और यहाँ पर कौन सी वाली नर्व सप्लाई करती है? दैट इज डीप पेरोनियल नर्व. वेरी मच इंपॉर्टेंट, सर. डीप पेरोनियल नर्व. And then the skin on the dorsum of the foot here will be supplied by superficial peroneal nerve, sir. Then the skin on the lateral side of the leg and lateral side of the foot here will be supplied by sural nerve. And the skin on the medial side of the leg, medial side of the foot, up to the ball of the great toe. Up to the ball of the great toe, that will be the saphenous nerve. And we know very well, saphenous nerve is actually the branch of your femoral nerve here, sir. Fine. And that is the sensory supply to your foot there. Okay. Plantar surface bhi ho gaya, dorsal surface bhi ho gaya. Entire concept is actually revised here, sir. Fine. Now, which nerve is primarily supplying the first web space here, my dear friends? The first web space will be supplied by the deep peroneal nerve. That is the right answer here, sir. It is supplied by deep peroneal nerve. Perfect. Dr. Swikar is telling still 40 slides are left over there. Oh, you're counting from there. In that 40 slides, actually 20 will be questions and 20 will be explanations, Swikar. So 20 questions remaining. Okay. Don't look at the time and don't look at the slides over there, guys. If you want to learn something good, God knows, out of all these questions, all these important high-yield topics, definitely यहाँ से सवाल आएगा. And who knows, अगर आपका वो एक मार्क भी करेक्ट हो जाएगा वहाँ पर, there will be a difference of thousands and thousands of ranks, my dear friend. You know that very well, है ना? तो थोड़ा सा have patience and learn properly. Okay, so give your 100% and learn the things properly over here. Don't be impatient guys. ठीक है? आगे बढ़ते हैं. So hardly we are left out with like few questions right now. We'll finish it off in another like 20-30 minutes, and then we'll leave, guys. Fine. Which of the following statements are true? Now please remember option A here, ranula arises from the obstruction of sublingual gland duct. Yes, of course, it is absolutely correct here. It is sublingual gland duct obstruction only. Thyroglossal cyst moves with the swallowing and tongue protrusion. ये भी बिल्कुल सही है. आपको दो चीजें आपको यहाँ पर याद रखनी होगी. थायरोग्लॉसल सिस्ट जो होता है दैट इज गोइंग टू मूव विद एट द प्रोट्रूजन ऑफ द टंग सर. प्रोट्रूजन ऑफ टंग ये बहुत इंपॉर्टेंट होता है, याद रखना. अपार्ट फ्रॉम दैट थायरॉयड ग्लैंड स्वेलिंग भी होता है. आई विल टेल यू अबाउट दैट लेटर ऑन व्हाई इट इज हैपनिंग एंड ऑल. आई एम हैविंग वन क्वेश्चन रिगार्डिंग दैट वन. वी विल डिस्कस इन डिटेल अबाउट द थायरॉयड स्वेलिंग सर. Branchial cyst arises from the persistent second branchial arch cartilage. No, this is absolutely wrong. Normally what will happen, the second arch will be growing faster here, and because it is growing faster here, therefore it is going to enclose a space here, sir, and that space is referred to as sinus. Which sinus? Cervical sinus here. I hope you have learned about the pharyngeal cleft and pharyngeal pouches. Cervical sinus होती है यहाँ पर. And normally what should happen, this cervical sinus should be closed. That is the reason why now in your body and my body right now, if the cervical sinus is closed here, sir, this part is completely smooth here. अगर ये रह जाती है, if cervical sinus persists, that condition is referred to as branchial cyst, or else it is also referred to as branchial fistula. Okay, so this is a wrong explanation given here, sir. Cystic hygroma is a congenital malformation of the venous drainage, venous system. No, actually it is actually about the lymphatic system. So this is also a wrong statement here. A and B are the true statements here. Option D is the right. Chaliye. Match the nerve with its typical area of pain or hypersensitivity. Come on, are you ready? Can you match the nerve with its area of supply here? Lateral cutaneous nerve of the thigh. This is going to match with the lateral part of the thigh. Absolutely correct. अब यहाँ पर मैंने आपको ये सवाल इसीलिए दिया है, many a times they are asking the questions regarding the meralgia parasthetica. In obesity, in pregnancy, and in wearing the tight clothing and all, what is going to happen? The lateral cutaneous nerve of the thigh will be compressed near the inguinal ligament, leading to, yes, tingling sensation or the pain in the lateral aspect of the thigh. That condition is referred to as meralgia parasthetica. Meralgia parasthetica, sir. So what is the nerve that is involved in the meralgia parasthetica? That is the lateral cutaneous nerve of the thigh. And yes, of course, it is supplying to the lateral aspect of the thigh. And you also have to remember the root value here. That is your L3 and, sorry, lateral cutaneous nerve of the thigh is going to begin from L2 and L3, sir. Perfect. Okay. Number 1 matches with D. In all the options, it is matching with D only, sir. Okay, fine. Number 2. Ilioinguinal nerve. It is the one which will be supplying to the medial thigh and the penis shaft here, sir. So in this diagram, you can actually see here the ilioinguinal nerve. It is actually supplying to the shaft of the penis over here. And then 3 here, sir. That is iliohypogastric nerve. And iliohypogastric nerve is actually supplying to the suprapubic and groin region. तो यहाँ पर आपको नजर आएगी iliohypogastric nerve. It is supplying to the suprapubic and the groin region, sir. And finally, this one here, the genitofemoral nerve. It is the one which will be supplying to the scrotum, that is homologous to labia majora in the female and upper anterior of the aspect of the thigh, sir. Yes, you can clearly see here the genitofemoral nerve here, supplying to the scrotum as well as the upper aspect of the thigh. So therefore, the correct match here will be the option D here, sir. That is the right match. Perfectly done, sir. Okay. So in this manner, we are done with the sensory supply of your lower limb here. These nerves are very much important here, sir. Identify the given histology slide. This slide is also like repeatedly given your exam, sir. Yes, you can clearly see this slide is actually having a cluster of cells in the middle surrounded by that exocrine part of the pancreas. So these cells which are actually present here are representing your islets of Langerhans over here, sir. The condition mentioned are caused by dilatation of which of the following portosystemic anastomosis. Now I hope all of you have learned the portocaval anastomosis in detail here. When you learn about the portocaval anastomosis between the portal vein and the inferior vena cava, yes, the three important conditions that you have to remember here. Number one, the lower aspect of the esophagus, the lower part of the esophagus. अगर यहाँ पर veins dilate होती है तो उसको हम कहते हैं esophageal varices. And then near the rectum, यहाँ पर क्या होगा, the veins dilate होगी तो उसको हम कहते हैं yes hemorrhoids. And then surrounding the umbilicus, यहाँ पर क्या होता है sir, there will be caput medusae. Okay, and you actually have to learn about the veins which are belonging to the caval system and the veins which are actually belonging to the portal system, है ना. पोर्टल वाले वेन्स आपको याद रखना होगा और केवल सिस्टम वाले वेन्स आपको याद रखना होगा यहाँ पर at 3 important locations here. So now let us see one by one here. Between the left gastric vein and the esophageal veins draining into the azygous and hemizygous vein causing esophageal varices. Absolutely correct here. अगर आपको देखना है तो यहाँ पर आप देख सकते हो. Okay, so the anastomosis which is actually formed over here near the lower end of the esophagus will be between what guys, the left gastric vein and the esophageal veins over there. Between the superior rectal, middle and inferior rectal veins resulting in hemorrhoids. Of course, this is the superior rectal vein over here and that is a part of your portal system, whereas the middle rectal, inferior rectal, that is a part of your caval system. It is going and draining the blood into the inferior vena cava, and that is the reason why this answer is also right here. Between the para-umbilical veins and superior epigastric and lateral thoracic vein resulting in caput medusae. Absolutely correct. The caput medusae is actually because of this para-umbilical veins surrounding that one. Between the inferior mesenteric vein and inferior epigastric vein resulting in caput medusae, no. In caput medusae, para-umbilical veins will be involved. So this is a wrong statement here. So A, B and C will be the correct statement with respect to A, B and C will be the correct statement here, sir, with respect to portocaval anastomosis. Okay, चलिए सर आगे बढ़ते हैं. Which muscle function is primarily tested by this one? I hope you all remember pad and dab. Palmar interossei will be actually helping in adduction of the fingers, and then dorsal interossei will be helping in abduction of the fingers here, sir. This is another hot favorite topic of your INI-CET examiner. They'll be asking like multiple questions from the interossei in a different manner. Now palmar interossei, it is helping in adduction of the fingers. If you give a card in the middle, if they are able to hold, that test is nothing but card test, sir. And for dorsal interossei, you'll be actually having the agava test over here. So therefore, my dear friends, remember the correct answer for this one will be the palmar interossei here. So in the given card test, we are testing which muscle here? Palmar interossei. And of course, all the interossei will be supplied by which nerve only? Ulnar nerve. So we can say that ulnar nerve is being tested over here, sir. During the Pringles maneuver, which of the following structure remains unclamped? I told you Pringles maneuver is done near the free end of the lesser omentum. And in the free margin of the lesser omentum, already I have shown you the picture in the peritoneal fold. In the free margin, you'll be having portal triad. So there, hepatic artery will be clamped, and then portal vein will be clamped, and common bile duct will be clamped, but not the hepatic vein, sir. So the correct answer here will be the B, sir, which is unclamped. That will be the hepatic veins. Next one. A patient presents with difficulty recognizing objects by touch despite normal sensation. What is this known as, guys? Identifying, the ability to identify the object just by touch without seeing. Okay, that is nothing but stereognosis. Damage to which of the brain area is most likely responsible for this sensory association deficit? Answer यहीं पर दिया गया है, sir, sensory association deficit. Okay. If you look at this superolateral surface here, in the temporal region, you'll be actually having two sulci. If there are two sulci, there'll be like how many gyri? 3 gyri. This one here will be the superior temporal gyrus, and this one here will be the middle temporal gyrus, and this one here will be the inferior temporal gyrus here, sir. In the superior temporal gyrus, you'll be having area number 41 and 42 here. That is the primary auditory area, sir. And just behind this one, there will be area number 22, and that one will be the auditory association area. So therefore, superior temporal gyrus is actually concerned with auditory. So therefore, ये वाला answer यहाँ पर नहीं होगा. And after that, inferior frontal is given. Okay. In the frontal also, it is the same thing. You are having two sulci. अगर दो sulci होंगे, यहाँ पर 3 gyrus होते हैं. What is the name of this gyri? Superior frontal gyrus. There will be middle frontal gyrus, and then you'll be having the inferior frontal gyrus. And in the inferior frontal gyrus, you'll be having area number 44 and 45 here. That is Broca speech area. So it is concerned with speech over here. So of course, ये भी answer नहीं हो सकता है. Now parietal lobules are given here. Now when it comes to the parietal lobe, in the parietal lobe you'll be actually having only one sulcus. So therefore there will be superior parietal here, and then there will be inferior parietal here, sir. Superior parietal is the one where you have the area number 5 and 7, and this one will be the sensory association area, sir. In the superior parietal lobule, you'll be having the sensory association area. Okay, so therefore, what is asked here? Sensory association deficit, that will be related with what? Superior parietal lobule, not the inferior parietal lobule, sir. Inferior parietal lobule is the one which is concerned with what here? Which is concerned with what here? It is concerned with hand and eye movement, sir. Inferior parietal lobule is concerned with hand and eye movement. Daily vibe, whatever you're telling there, 312, that Brodmann area number 312, that is primary sensory area. But here the deficit is actually in the sensory association area, not the primary sensory area, sensory association area. So that will be 5 and 7. Brodmann area number 5 and 7. Okay. चलिए आगे बढ़ते हैं sir. Which of the following connection is not a part of the classical papillae circuit? I hope you remember the papillae circuit. From the hippocampus here, there will be fornix. From the fornix, it will be taking the information to the mammillary body here. From the mammillary body, it will be going to the anterior nucleus of thalamus via mammillothalamic tract. Okay, and from there it will be going to the cingulate gyrus. That entire thing will be the papillae circuit. We have learned in detail about that one. तो चलिए देखते हैं सारे statements. Hippocampus to the mammillary body via fornix. Absolutely correct. And after that, mammillary body to the anterior thalamic nucleus via mammillothalamic tract. Absolutely correct. Please remember this anterior thalamic nucleus. That was also asked in the exam. Anterior thalamic nucleus to cingulate gyrus via thalamocortical radiation. Absolutely correct. Now our last one here, basal ganglia to prefrontal cortex via internal capsule. Actually, this one is not a part of the papillae circuit. ये papillae circuit वाला part नहीं होता है. Is it okay? Basal ganglia to the prefrontal cortex via the internal capsule and all those things, that is concerned with the movements and all those things, sir. Papillae circuit का part ये नहीं होता है. Now, which clinical test assess the function of greater petrosal nerve? Greater petrosal nerve किसका branch होती है? For example, if this one here will be the pons, in the pons there will be 6th nucleus, and then there will be 7th nucleus. 7th nerve will be taking a turn around the 6th and coming out. This is the 7th cranial nerve, so that is your facial nerve. And wherever it is going to take a turn here, यहाँ पर एक elevation form होता है, इसको हम facial colliculus कहते हैं. This topic is also extremely important for your INI-CET exam, sir. Facial colliculus will be formed due to which nucleus? Remember, 6th nucleus, not the 7th nucleus. Why the name is given as facial colliculus? Why? Because the facial nerve is going to take a turn around that one. Understanding? So remember, many a times in your INI-CET exam, they have given a question regarding this one. Now, the facial nerve is going to first move laterally, then it is going to take a turn and go backwards, then it is going to move downwards, sir. That is how the facial nerve is actually going to travel. Now, at this bend here, there will be a ganglion, and that ganglion will be geniculate ganglion. And near that geniculate ganglion, what is going to happen? It is giving a branch, and that is greater petrosal nerve, which will be finally going and ending in a ganglion, and that ganglion will be pterygopalatine ganglion. And finally, from here, another nerve is going to begin. Pterygopalatine ganglion, and from here another nerve is going to begin, and finally that will go and supply to lacrimal gland, sir. Lacrimal gland. So greater petrosal nerve somehow यहाँ पर आती है. Fine. So it is the one which will be supplying to which gland? Finally, lacrimal gland. तो इसके लिए जो tears formation होता है, जो test किया जाता है, that is nothing but your option A. Option A, sir. Is it okay? Dr. Aparna, Dinesh, we are almost at the end. That's the reason why there is no meaning of giving a break here. Another 10-15 minutes we will be done. So have some patience. We'll be completing this one here. The chest x-ray which is shown below demonstrate a characteristic finding. The congenital defect depicted results from which of the following abnormalities? Embryological abnormalities. Okay. What is this representing here? This is actually representing the egg on string. Egg on string. I hope you have learned about this one in the radiology. Egg on string करके होता है, okay? और ये किस कंडीशन में होता है सर? दिस विल बी एक्चुअली इन द TGA, ट्रांसपोजिशन ऑफ ग्रेट आर्टरीज, ओके? अगर आपको याद होगा, when I taught you about the development of the heart, in the development of the heart at the cranial end there will be truncus arteriosus, bulbus cordis, and after that there will be primitive ventricle, primitive atrium, and then sinus venosus, okay? And truncus arteriosus is the one which is actually going to form two blood vessels. One will be the ascending aorta, another one is a pulmonary trunk. In between them, there will be a septum formed here, and this septum will be referred to as the spiral septum. And that spiral septum actually has to spiral so that the blood vessels, like ascending aorta, is actually coming from the left ventricle and the pulmonary trunk is coming from the right ventricle properly. अगर मान लो वो spiral नहीं होता है, if it is not going to spiral, then it will be kind of opposite, and that is referred to as the transposition of great vessels. ट्रांसपोजिशन ऑफ द ग्रेट वेजल्स, अगर वो स्पायरल नहीं होता है तो, ओके ना? सो देयरफॉर इट इज ड्यू टू द abnormal spiraling of the conotruncal septum. Now please don't get confused with this conotruncal septum, sir. It is nothing but spiral septum plus bulbar septum together. Spiral septum plus bulbar septum together, it will be referred to as conotruncal septum. And even remember that is also derived from the neural crest cells only, sir. Neural crest cells only. Fine. चलिए सर आगे बढ़ते हैं. Let us go ahead right now. Which fascia is closely associated with the ligament of Berry, providing important surgical landmark during thyroidectomy? Now, if this one here will be the thyroid cartilage, in the larynx, this one here will be the thyroid cartilage here, sir. We are seeing the thyroid cartilage from the side view. Below the thyroid cartilage, this one here will be the cricoid. Okay, this one here will be the cricoid. Now here what is going to happen, there will be thyroid gland here. मान लो this one is your thyroid gland here, sir. We are seeing from the side view here, thyroid gland. Now that thyroid gland is enclosed by a fascia, and that fascia will be the pretracheal fascia. We have learned about this pretracheal fascia in the neck region. It is one of the modifications of deep cervical fascia. Now this pretracheal fascia is the one which will be having one modification in turn attaching to the cricoid over here, and this one will be the ligament of Berry. Ligament of Berry, sir. Now read the question again, you will understand, guys. Okay, which fascia is closely associated with the ligament of Berry, providing important surgical landmark during thyroidectomy? Of course, the answer will be the pretracheal fascia. Ligament of Berry is actually the modification of that pretracheal fascia. I hope you're understanding with this diagram in a crystal clear manner. चलिए सर आगे बढ़ते हैं. Which of the following statement about the white matter tracts in the brain are correct? Okay, we have to learn about the white matter fibers. I hope you can recall my class, guys. White matter, bundle of axons, association fiber, commissural fiber, and projection fibers will be there, guys. Okay, so now let us see one by one. Corpus callosum is a commissural fiber connecting the two hemispheres. Of course, this is a correct statement. Out of all the commissure, in fact, corpus callosum is the largest commissure connecting the two cerebral hemisphere. Superior longitudinal fasciculus is an association fiber. Yes, it is the association fiber. It is connecting the different lobe, frontal lobe with the occipital lobe. Of course, different lobe within the same hemisphere. This is also correct. Okay. Hippocampal commissure of fornix is an association fiber. See, the funny thing here is that the name itself is telling hippocampal commissure. It is a commissure, not the association fiber, sir. Corona radiata is a projection fiber connecting the cerebral cortex with the lower part of the brain centers. Fine. Bilkul correct hai, sir. Projection fibers are in turn divided to three categories. Number one, there will be corona radiata. Number two, internal capsule. Number three, there will be tracts. they are the one which are connecting in up and down direction. So they are connecting the cerebral cortex down with the lower parts of the brain, sir. That is corona radiata. So option A, B and D is correct here. A वाला correct होता है sir, ठीक है ना? Which type of epiphysis is the structure highlighted in the given image? The structure which is highlighted in the given image here, this is greater trochanter. Epiphysis is nothing but the end of the bone. The one which is articular, which is involved in joint, that one will be the pressure epiphysis because it will be weight bearing. And the end of the bone which is actually non-articular and which is formed by the pull of the muscles, the traction of the muscle, that is traction epiphysis. अगर आप मेरा ये hint याद रखोगे, done, you will be able to solve the question perfectly, sir. Okay. अब आप मुझे ये बताइए, क्या ये ग्रेटर ट्रोकैंटर, लेसर ट्रोकैंटर, क्या ये जॉइंट में इन्वॉल्व होते हैं? क्या ये आर्टिकुलर है? नहीं है, दे आर नॉन आर्टिकुलर. सो रिमेंबर, इट इज एक्चुअली एन एग्जांपल ऑफ ट्रैक्शन एपिफाइसिस. दैट इज द राइट आंसर. अगर मैं आपको यहाँ पर सवाल में दूं कि देयर इज हेड ऑफ द फीमर, हेड ऑफ द फीमर इज विच एग्जाम्पल, विच टाइप ऑफ एपिफाइसिस? इट इज प्रेशर एपिफाइसिस, क्योंकि वो जॉइंट में इन्वॉल्व होता है और वो यहाँ पर एक्चुअली वेट बेरिंग होता है, इसीलिए इसको प्रेशर एपिफाइसिस हम कहेंगे. ओके, दैट इज हाउ यू आर गोइंग टू डील विद दिस वन हियर, सर. Then after this one, all of the following structures are composed of the type of connective tissue shown below except what? First of all, you identify this connective tissue here, sir. This connective tissue which is present here will be the dense connective tissue. That too, it is irregular. Dense, irregular connective tissue, sir. Fine. Now what is asking here? It is present in all of the following except what? So the dense connective tissue is present in the dermis of the skin, the capsule of the kidney, periosteum of the bone, but not in the anterior cruciate ligament. In the anterior cruciate ligament also you'll be having dense connective tissue, but that is regular one, sir, not irregular one. It is a regular one. Okay. चलिए आगे बढ़ते हैं. A 25-year-old athlete presents with anterior thigh pain after sudden sprint. On examination, he has weakness in extending his knee and flexing his hip. Extending the knee and the flexing the hip. Okay. MRI reveals a strain in one of the quadriceps muscle. Okay. That crosses both hip and the knee joint. अगर आपको याद होगा, मैंने अभी अभी आपको बताया था, in the attachments on the femur, rectus femoris. Rectus femoris कहाँ पर अटैच होता है? Rectus femoris will be attached on AIIS, anterior inferior iliac spine. That means it is going to cross hip joint, okay, and it is also going to cross the knee joint. अच्छा, तो अगर वो यहाँ पर contract करेगा, if it is going to contract here near the hip joint, it is going to pull. Pull means what? It is going to help in flexion at the hip joint. At the same time, if this muscle is going to act here at the knee joint, it is helping in extension at the knee joint. Flexion at the hip joint, extension at the knee joint. Yes, of course, the correct answer here will be rectus femoris. That is why that attachment is very much important. We have discussed about their attachment very well. Okay, next one, sir. A 35-year-old male presents with difficulty urinating and pain in the perineal region after straddle injury. Straddle injury बोलते ही आपके माइंड में क्या आना चाहिए? मैंने आपको क्लियरली कहा था, बल्बार यूरेथ्रा आना चाहिए. Okay. Imaging reveals that injury is limited to the deep perineal pouch. It is not extending into the deep perineal. It is limited to the deep. Which of the following structure is least likely to be affected in this injury? Okay. Now, I told you very clearly here, if it is straddle injury, bulbar urethra has to be involved here, sir. Okay, no? That means that will be present in which perineal pouch? It will be present in which perineal pouch, sir? It will be present in, yes, the superficial perineal pouch. Whereas the imaging reveals the injury limited to the deep perineal pouch, it is telling here. So basically आपको क्या करना होगा? You have to see all the contents of the deep perineal pouch that will be affected here, sir. अगर आप ये डायग्राम देखोगे, मैंने आपको क्लासेस में बड़ा क्लियरली बताया था how to remember about the perineal pouches, sir. First of all, there will be a urogenital diaphragm here. And that urogenital diaphragm will be having one fascia above, one fascia below, sir. Superior fascia and inferior fascia. And that inferior fascia itself is referred to as the inferior fascia is also referred to as the perineal membrane. तो पेरिनियल मेम्ब्रेन के ऊपर वाला जो पाउच होगा वो होगा डीप पेरिनियल पाउच, और उसके नीचे वाला ये जो पाउच होगा वो होगा सुपरफिशियल पेरिनियल पाउच से. In the classes I told you very clearly with the help of three fascia here, sir, ऐसे याद रख लो. One will be the superior fascia of urogenital diaphragm, okay. Inferior fascia of urogenital diaphragm, okay, which is also referred to as perineal membrane. And then यहाँ पर होगा superficial fascia, और इस फेशिया को हम यहाँ पर कहते हैं कोलिस फेशिया, सुपरफिशियल फेशिया और कोलिस फेशिया. अगर यहाँ पर तीन फेशिया होंगे, इफ दे आर लाइक थ्री फेशिया हियर सर, between them there'll be two pouches. This will be the superficial perineal pouch and this one here will be the deep perineal pouch. Done. इतना आसान है. Many of the students will be having a big headache understanding like what are the boundaries of the perineal pouches. Remember there'll be three fascia and between them there'll be two pouches. तीन फेशिया होंगे और उनके दरमियान में दो पाउचेस होंगे. डन डन डन. अब यहाँ पर द इंजरी इज लिमिटेड टू डीप पेरिनियल पाउच वो कह रहे हैं, तो ऑब्वियसली डीप पेरिनियल पाउच में क्या होगा, यूरोजेनिटल डायफ्राम. तो इफ इट इज यूरोजेनिटल डायफ्राम तो ऑब्वियसली रिमेंबर दैट द स्फिंक्टर यूरेथ्रे मसल एज वेल एज द membranous urethra as well as the bulbourethral gland, all these are actually present in the deep perineal pouch. आप देख सकते हो यहाँ पर bulbourethral gland, the sphincter urethrae muscle as well as membranous urethra, all of them are present in deep perineal pouch, okay, except for what, ischio-cavernous, this will be found in the superficial perineal pouch. ये superficial perineal pouch में होगा, तो इसीलिए the structure which will be least injured here will be the ischio-cavernous one, sir. That is the right answer. Option D is the right answer here. Okay, if you want like more clarity on this one here will be the bulb of the penis here, and on either side of the bulb of the penis there will be crest of the penis, and that crest will be surrounded by ischio-cavernous muscle. ischio-cavernous muscle sir, तो obviously कहाँ पर होगा, superficial perineal pouch में होगा सर. ठीक है ना, चलिए आगे बढ़ते हैं सर. So these are all the contents of the deep perineal pouch, already मैंने आपको बता रखा है. Identify the correctly matched label structure in the lung histology slide. Now why I have given you this one here, as I told you there are so many histology images given in this a rapid revision reignite here. Yes, one of the histology image which is repeatedly given in your exams nowadays is this one here. So first, this one here will be the terminal bronchiole. Sir, how can you tell it is the terminal bronchiole here? Try to recall, after the terminal bronchiole in the respiratory bronchiole, वहां से क्या होता है ना, alveoli form होना स्टार्ट हो जाते हैं. पहले terminal bronchiole होगा, फिर respiratory bronchiole होगा, after that that is going to continue that into the alveolar duct, and then you'll be having the alveolar sac, and then there will be alveoli. Fine. So from the respiratory bronchiole itself what is going to happen, the alveoli formation will start. तो इसीलिए how to differentiate कि सर ये वाला terminal ही होगा और ये वाला respiratory bronchiole ही होगा. तो whenever they are giving this type of image in the exam, remember if it is like proper wall present over here, till that it cannot be the respiratory bronchiole. जहां पर आपको complete wall नजर आ रही है, it has to be what here sir, it has to be the terminal bronchiole. Then after that the alveoli formation will begin. तो वहां से आप differentiate कर सकते हो, respiratory bronchiole होता है, and later on there will be alveolar duct, and then you'll be having the alveolar sac sir. I hope you'll be able to manage with this one here. Okay. तो नंबर 1 यहाँ पर जो दिया गया है, the number 1 which is given here sir, this one here will be the respiratory bronchiole. तो it cannot be option B, it cannot be option C. Number 1 is respiratory bronchiole. Okay. Number 2 यहाँ पर जो दिया गया है वो terminal bronchiole है sir. तो number 2 is terminal bronchiole. So option A will be the right answer here. Followed by you can manage. I have given you this image over here sir. That is the way how you are going to identify this image. Which of the following correctly list the structure in the cubital fossa in order from lateral to medial? Cubital fossa, first you'll be having median nerve, then the brachial artery and branches, then the biceps brachii tendon, and then the superficial branch of radial nerve. And this is the arrangement from where to where? From medial to lateral. MBBS, from medial towards the lateral. And now in the question there, they're actually asking from lateral to medial. So I hope you'll be easily able to manage with this one here, sir. सबसे lateral side में यहाँ पर क्या होगा? Radial nerve होगा. Then after that there'll be biceps brachii tendon, then brachial artery, then the median nerve, sir. Option A will be the right answer here. Cubital fossa. Once in your exam, they have actually given this as cadaveric image also. So in the cadaveric image also, you should be able to identify all the structures present in that one. That is the reason why I am discussing about the cubital fossa contents here. आपको यहाँ पर पहचान आना चाहिए, पहले मीडियन नर्व होती है, फिर ब्रेकियल आर्टरी ब्रांचेस, फिर बाइसेप्स ब्रेकिया टेंडन, और फिर क्या होगा सर? सुपरफिशियल ब्रांच ऑफ द रेडियल नर्व. A 65-year-old bedridden patient develops aspiration pneumonia in the recumbent position. Which lung segment is most commonly affected? Now in this position, remember the segment of the lung which is most commonly affected will be the posterior segment of the upper lobe, right upper lobe. Posterior segment of the right upper lobe, sir. So in the upper lobe of the lung, I hope you all remember in the lung we have learned about the bronchopulmonary segment. In the upper lobe of the lung, you'll be having three segments: apical, anterior and posterior. The posterior segment will be involved over here, sir. Which of the following statement about the levator ani will be false statement here, sir? तो basically हमको यहाँ पर false statement देखना होगा. Levator ani, which belongs to your pelvic diaphragm. It arises in part from the tendinous arch of the obturator fascia. This is a true statement here. It receives the motor innervation mainly via the branches of anterior rami of sacral nerves S3, S4. Okay, this is also true statement here. Its puborectalis component maintains the anorectal angle to aid the continence. Yes, we have discussed already about the anorectal angle, and that is maintained by puborectalis muscle. It is going to maintain that angle, and because of that, it is not like incontinence, it is helping in continence actually. That is also a true statement. It is supplied exclusively by the pudendal nerve. No, 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 no. This is a false statement. Already यहाँ पर बताया है. It is supplied by the anterior rami of sacral nerves. That is nothing but your S3 and S4, sir. And by this, we are done with all the questions that were given in your tests in the anatomy, sir. And by this, we have discussed like all the concepts in detail. I hope you have found this session like useful to you. है ना? So we have discussed like all the important high-yield topics which will be asked in your INI-CET exam, my dear friends. So by this, we are done with this one. So do attend all the tests. The schedule is given to you. It's very much useful sessions over here. So the test will be conducted at 12 o'clock, and of course the faculties will be discussing at 5 p.m. So I hope this session was useful to you. Yes, my dear friends. Thank you, Dr. Mohan. Thank you, Noor Sultan. Thank you, Mini Shak. Thank you, Dr. Krish. Thank you, Dr. Svikar. Thank you, sir. High yielding session. Thank you. Yes, of course, it was a very, very high yielding session, and many concepts has been cleared here, sir. So I wish you best of luck for your preparation. Keep preparing. God bless you. God bless you with nice health. Thank you all. Take care. Dr. Azam signing off here.